All right. Good morning, everyone. My name is Annette Decker. I am a research fellow at UCLA, and I'm very excited to see you all and that you all are joining us for our physician advocacy workshop today. I hope it will be a fruitful discussion on many different aspects of advocacy and activism. I'm joined here by several of my colleagues, Dr. Shea, Dr. Kanzaria, Dr. Samuels, Dr. DeLuca, and Dr. Janeway and Dr. Summer will be joining us a little later this morning. I'm going to go ahead here and share my slides, but I just wanted, before I did that, for everyone to be able to see each other. Give me one moment. All right, everyone can see my slides okay? Excellent. So again, welcome. As we all know, advocacy is a big part of our lives here as physicians. And I think especially in the past 12 months, a lot of us would agree that the lives of the patients that we serve and the communities that we take care of have been dealing with a lot of injustices. And we as physicians have really, I would argue, risen up to the occasion in activism in many different forms. So as you see here is an all too familiar picture of white coats for Black lives in support of the Black Lives Movement. And arguably, we've also been doing a lot of activism in terms of COVID and activating or acting as advocates for our patients and access to resources for communities that have been disproportionately infected. And perhaps a little less acknowledged is also the activism that's been happening around the world. So this is a picture of physicians in Myanmar. So on February 1st, there was a military coup. And in response, physicians around the country actually staged a protest and walked out of the hospitals for a day. And this is a photo of such. And I think in a lot of ways, we feel like the advocacy that's been happening last year is unique. I know, at least I feel like it's been certainly an interesting year. But I want to just remind us that the advocacy that we do as physicians is not new to 2020 or 2021. So this is actually a photo of a free clinic by the Black Panther Party. And this picture is notable because it's actually the clinic that Mary Bassett worked at. So before she was the New York City Health Commissioner from 2014 to 2018, she actually, well, I guess really at the beginning of her career, she was working for the Black Panther Party and helping them with their clinics and led a screening campaign for sickle cell. This is a photo of Dr. Fitzhugh Mullen. You guys may know the book that he wrote, White Coat Clenched Fists, but what you might not know is that when he was a resident in New York City in the Bronx, he actually helped the young lord stage a protest at a hospital called Lincoln Hospital. And so they actually took over the hospital for a day to advocate for improved facilities. So my point here is that advocacy as physicians is old as time. And I can't talk about advocacy without, of course, bringing up Dr. Virchow. Some argue that he's really the founder of social medicine, and he coined the term, the physician is the natural attorney of the poor. So in a lot of ways, we have been doing advocacy for a long time, and I'm sure that each of you here has been involved in advocacy. I do want to clarify one point before we get too much further with the day. I've been using the words both advocacy and activism, and I do want to clarify the two. So advocacy is really when we're talking about working within the system, and activism is talking about working outside the system. And I bring these up not because one is necessarily better than the other, but because I think it's important to recognize the distinction and that each have fairly separate tools into how you go about doing them. And that at its best, the two of them actually work hand in hand quite well together. So there's a quote that there's a role, sorry, I hit the wrong button there, give me 1 second. There's a quote that there is a role for the activist who walks into the building while activists make their voice heard outside of it. And so this is going to be quite relevant when we go through the different sessions today. So, here I'm just giving an introduction, but in a little bit, we will hear from Dr. Shea and Dr. Kanzaria talking about advocacy and really how do you make change within your hospital system. And then we'll lead into more direct activism led by Dr. Janeway and Dr. DeLuca. And then a little later in the day, we will hear from Dr. Samra about community collaboration. So as we're getting started here, I just want to open up the floor to see if there are any questions getting started. But while we transition PowerPoint presentations, I actually would love if everyone is able to, in the chat, just introduce themselves in terms of where they are coming from, perhaps where they are in their training, and most specifically, if there's a topic that you are interested in related to advocacy. So whether it be immigration, gun violence, et cetera, just so we can have a sense of where you're coming from.
Great, Annette. Thanks so much. Do you want us to go ahead and get started or give people a couple minutes to read the chat?
I think you can go ahead and get started. And again, feel free kind of as this next presentation is going on to just say what you're interested in terms of advocacy and how we can make sure that we get the most out of the session.
Great, thanks so much, Annette. My name is Dennis Shea. I'm currently Chief Medical Officer at Contra Costa Health Plan and also clinical faculty at Harbor UCLA. And Hemel is co-presenting with me. I'll let him introduce himself.
Morning, everyone. I'm Hemel Kanzaria. I am an ED doc at UCSF. I'm the medical director of care coordination here.
Great. So I think for us, as Annette said, we're very much focused on advocating within your system and sort of looking for change. So for us, we wanted to just run through a couple basic things in terms of a framework and an approach about how we think about advocacy, followed by an application of the framework and the approach through a few examples from both of our experiences. And not so much to say this is what you have to do, but really to sort of try to put the conceptual framework to life. And then really throughout the session, we're hoping to be able to answer your questions and have this be engaged. So feel free to sort of pop in with questions. We hope that we've saved plenty of time at the end for Q&A and really to get everybody discussing, because I think we want to make the session useful and applicable to you, not just to hear about two people's experiences in the abstract and say, oh yeah, they did some cool stuff, but how does this work for me? The real goal is to sort of get you thinking, and hopefully the examples will do that on how you can sort of bring this approach back to your own institution. So in terms of framework and approach, so I think the first thing for both of us is really thinking through issue identification. And I think this is probably the easiest part. You're probably all here, as Annette said, to put you have an idea of an issue or several issues that you care about that you really want to work on. And it's probably pretty intuitive. And I think part of the issue identification is making that into a solid question of what is exactly the problem that you're trying to solve, and making it in a way that people can understand it. So, something, for example, like addiction or social needs, very broad issues that we're all very familiar with as emergency medicine physicians or trainees. However, how does that translate into something actionable? And I think really that's sort of the question of what's the problem you're trying to solve, and how do you sort of hone that down into something that is not saying, I want to solve poverty or I want to cure poverty, which is, I think, something that's very important that we're all striving for, but really sort of making it something that you can do that's manageable, that people at your institution can see as doable, relatable, and be able to really work with you on. I think part of this is most of the problems you're looking at are probably not issues unique to your institution. So in terms of doing your homework, not just sort of understanding how to frame this locally so that it's relatable, but also sort of looking both in the literature and just talking to your peers, your colleagues, and looking at what's been done across the country. And I think really that'll help you sort of hone this down a little bit and take it from potentially sort of a big abstract, not so much abstract, like a big, real issue to something that I think is manageable and for you and your team, depending on sort of the resources and your level of training. And then I think sort of related to doing your homework is very much don't be paralyzed by researching the problem or having to feel like you have the perfect answer. As you'll sort of see through the whole process, a lot of this is not just coming up with something, being able to take a first pass and being 100% successful. A lot of this is very much coming up with something, being brave and sort of find your allies and being able to move forward and being able to do rapid cycle improvement. I think after you've identified the issue, really understanding incentives and motivations of those at your institution and also perceived or real barriers. I think a lot of this is very much key because, sometimes you may work at a mission-driven institution that cares exactly about the issue you are thinking about and very excited to work with you. Sometimes it may be something that is not necessarily a priority, especially given the past year with COVID, or even worse, it may be something that's potentially perceived as a polar opposite of what your institutional leaders are interested in, whether that be financial, whether that be mission, whether that be something else. So I think really getting an understanding of what your institutional leadership is interested in and those who you need, and really framing the issue to be aligned with what they're interested in is key. And I think part of this is really using common language or terminology, whether it be, as Hemel covered in a little bit, using a quality improvement or improvement framework that your institution uses, such as Lean, or sort of focusing on the priorities, whether that be throughput, door-to-dock times, readmissions, finances, or penalties. I think really sort of getting that understanding and sort of being able to frame what you're interested in those terms, so that you can really get buy-in and get relation from your leadership. And then I think as a lawyer, I always like to point out researching rules, regulations, and policies, because I think this is often something that people love to tell you or use to tell you no. And I think there's all sorts of examples of this, right? When I was working in LA, there was a huge issue with people getting on food stamps, or CalFresh as it's known, or SNAP. And the big issue was IDs were being scanned and the scanners were horrible. And basically what happened was a lot of the images were illegible. So when our Department of Public Social Services reviewed it, they disallowed people because they couldn't see the ID. However, obviously the person scanning it in was reviewing an original ID and attesting to it. And there was a discussion as to whether or not we could have an attestation in addition to a scan, whether it was good or not, since there was proof. And this was really a technical error on the part of the institution, as opposed to any problems with the patient. A lot of people said, no, of course not, we can't do that, because either they didn't want to do it, or they didn't think we could do it because that wasn't the way things have always been done. But if you actually go back and look at the law, there's nothing, the legislature doesn't think to that level of detail. And most institutions don't think to that level of detail. They just said there has to be a proof of identity in some way. So we were able to implement that change and really cut down on denial rates. And then I think after you sort of done your homework, researched, got to your terminology, it's really about stakeholder engagement. And part of that is understanding the current state as to what's going on, what's happened previously, why things worked or didn't work. So you're not coming in as sort of someone who comes off as someone who's just, highly idealistic, or someone who is naive and doesn't really understand the nuances. And then really, I think, taking it back to basics, really messaging your idea and getting feedback on it. And I think often, sort of going back to the previous slide, you'll have people who will throw lots of objections at you, anything from the littlest thing, such as, oh, well, there's no hand washing station next to where you want to do it, and that's going to be a barrier, to big issues such as, that's not financially doable, that violates HIPAA, all sorts of things. And I think really the big thing there is focusing on sort of going back to, the initial thing, focusing on the issue, focusing on your messaging, and really focusing on the basics, getting alignment on the basic thing, right? Like you can always frame it in a way similar to what politicians do. Nobody wants to be seen as hating babies or puppies. So I think you sort of have to take your issue and kind of do it that way and take it back to the basics, being like, well, do you really want people to die? Because that's horrible. I'm sort of saying that facetiously, but I think you get the point in terms of really sort of honing the message and sort of taking away some of that distraction, not really necessarily ignoring it if it's a big issue, but sort of swatting away some of the smaller issues. And then getting feedback on your idea. Like I said, some of the bigger issues, you will have to modify your approach for what you're thinking about because people are going to have really good perspectives. But sometimes people will raise little things like, oh, how about, this or that. For example, we're doing social needs screening in LA. And one of the big things is, how about EMR integration, which is not really a little thing. It's a key part of workflow, but it's sort of putting the cart before the horse. So sort of having a way to address that, say, yeah, that's definitely part of the plan. That's valid, but that's going to be step 3. We've got steps 0, 1, and 2 first, and sort of getting that taken care of. And then I think, as I said, modifying as needed to really get that buy-in and partnership. And then I think really this is the last part, right? Not letting the perfect being the enemy of the good. And really, in that sense, you have to get started, right? You can't be paralyzed by planning. And in that sense, so getting feedback as you go along and giving feedback and using certain data or metrics that you set forth or have discovered during the process to be able to present that. And then really sort of the 80-20 rule that Hemel likes to refer to, which is a large part of the issues are sort of caused by a few things. And so really focusing on those key primary drivers. And, there are a lot of other valid concerns, but those are really refinement. Sort of getting started, getting going is key. And I think sort of many of us can relate to this in terms of exercising. There's sort of all sorts of things you can do when you're planning to start a running program. But probably the hardest thing that we see for both ourselves and the patients is just sort of taking that first step and getting started. That's a large part of the barrier. So I think with that framework, I'd like to turn it over to Hemel to run through some examples from his experience.
Awesome. Thanks, Dennis. Can you stop sharing? Morning, everyone. Very excited to be here with you all and loved seeing all of your interests in the chat. All right, so everyone can see my screen? Awesome. So I'm going to talk through my general approach to health systems change using the framework that Dennis presented, and keeping in mind that, so at my institution, UCSF and ZSFG, performance improvement is sort of and lean is sort of the approach to change management. So when I started there, my mentors basically were like, if you want to learn a skill set and be a change agent, you have to learn this skill set. I don't think you have to learn lean. So at the most basic level, any performance improvement within your health system comes down to a couple main attributes. The first is really the scientific process. So it's doing some sort of systematic thinking that Dennis was talking about in terms of understanding your stakeholders, project planning. It's doing rapid cycle improvement and using data to drive improvement. And then it's, again, just working towards continuous improvement. There's not going to be a perfect end goal. It's just iterating over time and trying to do better over time. The second part of really change management, in my experience, is very simple, but it's worth stating out loud. It's really just the behaviors that you want to exhibit as a leader and support your team on. So it's really basic things like going to the place where the work is done. So if you're trying to do change management in the ED, great. You're all ED or ED interested or ED clinicians, you know that. You're the expert there. But if you're doing change management outside of the ED, whether it's in your medical system elsewhere or in the community, you may not be the expert in that yet. And so a lot of it is actually going to the place, understanding what barriers both clients or patients and staff are experiencing, and listening and asking questions and learning, and recognizing that the experts in that area may be frontline staff in that area, and really understanding what challenges they face and what ideas they have to overcoming that. The best ideas come from people who are, in the trenches, thinking about the challenges they're facing. And your job as a leader is to really support them in implementing some of their ideas. In any sort of improvement effort, really centering it on the patient and your colleagues for whom you're trying to do the improvement, and making that sort of the cornerstone of efforts that you support, and approaching your work with really basic principles. So the willingness to recognize that change has to happen and status quo is not good enough, that you really need to be persistent, and then bringing sort of humility and curiosity, understanding why things have not worked previously, understanding why things are not working now, and being sort of self-disciplined at sticking with it, using data to drive improvement. So I'm going to go through a couple examples from my own work. And again, the idea is to share the process, not necessarily what exactly happened. So shown here is an A3, which is a lean tool, but the main point is that it's a project planning document. We're not going to go through this today, but essentially over the last 4 years at our institution, we've created a framework for meeting patients' medical and social needs together. And this is my tool for stakeholder engagement. So I basically took this project planning document. Before we did anything, we took 6 months to really understand the current state, and then to meet with stakeholders both in our ED, outside of our ED, in the community. And we essentially just got their fingerprints on this work. So I would go to, if Liz was working in a community setting that was focused on housing or food, I would go talk with Liz and say, here are some ideas, here are some of the challenges my patients are facing. What do you think? What are the challenges that you have in relating and connecting with the emergency department? Is there ways we can work together and really get Liz's feedback on what would work and not work for her and her team, and then incorporate that into my project plan, and keep on iterating. So I did that with 50 different stakeholders. It was all about alignment. A3s and the sort of jargon in lean can feel really overwhelming. So I just want to simplify it. It's the same thing as a SOAP note that you've all learned during, med school. So for me, it was really understanding the subjective. So at the general, one of the executive team is really interested in flow. There's really poor flow of patients through our system. One small contributor to poor flow is admitting patients for primarily social needs. Our inpatient beds are our most limited resource. So understanding that was their main interest, that's how I framed this idea. So then I spent time learning about the current state. So we have a 16% admission rate. Most people stay for less than a day or two. Only 1 to 2 patients a day are being admitted for social reasons. So this is a very small problem on the spectrum of things. But our patients have a high prevalence of social needs. So over a third of our patients are experiencing homelessness, and our current system is really not set up to meet some of their social needs. That results in about 25 to 40 patients a day on the inpatient setting without acute medical needs. That limits flow through our system in terms of us being on divert. So again, framing it in the way that our C-suite really wanted to see the problem. So why does this happen? Why do we admit people for primarily social needs? So again, some of these things will resonate with you all. The ED doesn't have the support or the capacity to meet the needs of patients with complex social needs. We don't have any internal coordination, like an internal teamwork to really address patients' needs. The ED was really in a silo. We hadn't had any community partnerships or interagency partnership at that point. And then our system is really challenging to navigate for patients. Okay, so what are we going to do about it? So here's where here's some general ideas. Well, we want to develop a multidisciplinary team. We want it to be based in the ED to meet sort of the complex breadth of psychosocial needs. We want to develop some partnerships outside of the ED. And then we want to lower some of the barriers that our patients face in navigating our system. So I'm going to give you some examples. Our sort of concept was we would take a patient like Mr. D, who's coming in with cellulitis, but also experiencing homelessness and be interested in overcoming substance use disorder. And we'd sort of wrap him with multiple different services. So for the patients who, suffer a traumatic injury, We have, a trauma team and anesthesiology and respiratory therapy and social work. There's nothing remotely equivalent for patients with complex social needs in our system, who are honestly the majority of patients we see in our ED. So we thought for Mr. D, maybe we could just give him antibiotics, like his whole course of antibiotics walking out the door, so he didn't have to pay for them and make his way to a pharmacy and pay out of pocket. Maybe we could set him up for transitional housing from the ED, and maybe we could start medications for opiate use disorder. None of this was happening at the time. And the thought was we could potentially reduce the number of patients who were being hospitalized for lower acuity medical conditions, but high social complexity, and then really foster teamwork. And by teamwork, I really want to echo what Dennis mentioned around alignment. So it's folks in the acute care setting. So we're lucky, we're an urban safety net hospital, so we have social workers and pharmacists and care coordination nurses. But it's also people outside of our ED. So substance use navigators. It's more concrete linkages with our shelter health system, our EMS system. And over the last 4 years, we've developed partnerships with our Human Services Agency and other sort of agencies that focus on complex, that are better than the ED at helping people with housing insecurity or food insecurity. So part of this was really then doing rapid cycle improvement. So Dennis ended on that. And I'm not going to go into detail, but we've had sort of 20 plus different PDSAs that range from a consult service to giving people medications in their hand to helping people with housing. I'm going to go through one of them, the simplest one, which was essentially giving people medications for free. And even for this, you need to start somewhere. So part of our doing was coming up with a task list. And then it's really granular. So that's why I'm showing it to you here. It was identifying diagnoses that were associated with really short stay hospitalizations. So like 1-day hospitalizations, thinking about what meds are involved in those diagnoses. And then stakeholder engagement, meeting with the pharmacy leadership, the house staff leadership, getting legal approval for this to set up a satellite pharmacy in the ED. And it's really one common tool I use is who is going to do what by when. So a very simple operational framework and putting some visualization on it. So my whole team can see, okay, I'm going to do this. I'm hoping to get it to you by August. And did that happen or not? So very, very basic concept. And then I'll say that I think in medicine, we do a lot of plan, do, plan, do, plan, do, and there's not a lot of studying to see what happens. And there's not a lot of adjusting to make it better. So in the beginning, we just looked at how many referrals were we getting for this program? Were people using it? And if not, why not? And then adjusting based on that. So in year 1 of the program, most of the meds that we used were antibiotics for soft tissue infections. Bactrim, Keflex, prednisone, Cipro, et cetera. And then we got a lot of feedback from frontline clinicians saying, what else do you want? What else are we missing from that initial list? So people wanted anticoagulants for PE and DVT. They wanted furosemide for CHF. So really basic things that we had left off initially that we then started to use. So that's how we sort of iterated. Okay, second example was from this past year with COVID. And this was a really challenging situation in terms of, I remember personally sort of discharging people who were experiencing homelessness with COVID and just saying, I hope you can stay, self-isolate somewhere, or admitting everyone, because I, thought that was not a good plan to just discharge people with COVID to themselves. We've seen, unfortunately, in many places, China, Italy, New York, India, that mortality from COVID is related, excess mortality from COVID is really related to when hospital systems become over capacity. And so again, we try to provide an alternative to the hospital, but in a place where patients could get their medical and social needs met in an equitable and an effective way. So one additional sort of performance improvement tool I've used a lot of is the concept of standard work. So standardization of things that you do so that any staff member can come in. This is a piece of standard work for social workers at the hospital so that any social worker can help assess patients and refer them and get them successfully to a hotel site. I'm gonna sort of follow this up with like, okay, what was not working and how we walked through this. So this study was basically a relationship between the hospital and hotels in San Francisco to get patients experiencing homelessness safely to hotels. So in March, only 39 of 105 total referrals actually got to the hotels successfully. So a lot of people were not successful in that. We were not successful in supporting them. So we tried to ask why. Why were we not successful? And this gets at that 80-20 rule. We stratified out why people did not make it to the hotels. And again, just focused on the number one contributor. So the number one contributor was that the hotel site was denying referrals. So why were they denying referrals? Turns out very early in the pandemic, the hotels were not set up to meet the needs of patients with substance use disorders or with mental health needs. So we fed this type of data to our partners and our city leadership, and we said we need to create more, sort of better systems at the hotel system to meet these needs. And over time, that led to multiple new harm reduction services being offered at the hotel sites. So it was, twice daily wellness checks. It was food that meets dietary restrictions. It was a managed alcohol program. The first time we've been able to do anything like that in San Francisco, where we're dosing alcohol for people that need it twice a day. It was medications for opiate use disorder, counseling for stimulant use disorder, addiction care consultation that was available at the hotel sites. So that sort of data was what led to different harm reduction efforts being offered in the INQ sites. And then we did a lot of improvement work about getting people successfully to the hotel and not relying on the inpatient hospital beds, which we only have 150. So there's very limited capacity in our system. The bottom graph here shows that in the beginning, every single patient was being transferred from the hospital itself. These were all admitted patients, but over time that decreased because we got more people in from primary care, urgent care, ED. And I want to hone in on that. We really had to standardize these workflows across our system, across any clinical setting to make that happen. But looking at data and driving improvement in the way that we wanted to see was what helped move this project forward. My final point here, Dennis didn't talk about, but I think in my experience, something that results or that helps foster change is really combining data with stories. So when I meet with policymakers or potential philanthropic partners, I talk about patients I've cared for and I show the data, and that together, I think it creates a stronger case. So I'm not going to go through this, but I'll just end with that and I'll pass it over to Dennis again.
Great. Thanks so much, Hemel. So Hemel is much fancier than I am. So I'm going to talk to you through a much simpler case, something that you're all probably very familiar with in terms of medication-assisted treatment. And this is something that I think many emergency departments across the country have done it with various degrees of success. And I'm sort of going to use this example because I think sort of the workflow from all of us with experience and all those without experience that you've read is relatively simple. But I think sort of the challenges are mostly in the implementation. So, in terms of issue identification, this is something that we're all very familiar with, has a lot of compelling national, local data around why this is the right thing to do for patients. So I think that piece of it was sort of the easy piece. There's been a lot of funding over the last few years, especially right before COVID, and a lot of focus on this issue. So I think the motivation was there. There were resources available. And I think really in terms of alignment was really where a lot of different sites struggled in different ways. I think a lot of it was there were a couple of big things that were challenging. One was resources, which was often addressed through grants and a lot of the federal and state funding, including that what was available in California that we leveraged. But I think there was also philosophical alignment in terms of, is this the role of the emergency department? Is this the role of the hospital system? Are we sort of just perpetuating substance use and the stigma around that? And really sort of getting the buy-in, from everybody from hospital leadership to key pharmacy stakeholders to even nursing. And for us at Harbor, nursing was actually the hardest group to get buy-in from because I think there was a lot of personal experience in terms of interactions and difficult interactions around opiates and other substances, and really having to show, I think, both the evidence and also sort of some early successes was a way to really get additional buy-in. And I think, in terms of the other piece for the frontline provider is really time. And I think here, the challenge was both coming up with a simple workflow and showing that it was doable. It wouldn't take an extra hour, which we all know in the emergency department is not available to us, but also sort of trying to motivate in terms of time to do the X-waiver training, because that is another 8 hours, which I think we all think it's a good idea. But I think given 8 hours of our day, there are many things we can find to fill our time as opposed to sitting through a training. And then I think there was engagement, really, in addition to sort of understanding the different barriers, the different sort of stigmas around this, but really then getting out there and engaging, having that discussion, doing education, saying why it's the right thing to do, showing how it's very doable in terms of with, a different set of messaging for our nurses versus our residents and providers. And obviously you always have some early adopters, some late adopters. And I think for us, it was, really getting back to this last piece that was key, developing a very simple workflow, but then really going back, like Hemel said, using the data to drive this. And what we did was we used data around Narcan use, opiate prescriptions, other sort of proxies in terms of reasons for hospitalization, and really dug into the cases. We had a program assistant who would review every single case, find the cases where there were individuals with opiate use disorder, and then reach out to the providers. We had created a set of messaging that we had vetted, and either sort of reinforcing behavior, thanking them for prescribing buprenorphine or offering buprenorphine, or alternatively doing education, reminding people, oh, this was a case, we know not every case it's appropriate. We didn't see any documentation in the chart as to whether or not you considered this. Is this something you considered? And really over time, I think over the course of a year, I think the big barrier here, for us was not so much implementing the process or getting philosophical buy-in. It was really getting people to incorporate it into their practice. And that was sort of where we're falling short. And I think the data very much with that personalized feedback ended up being really a way to get people over the hump. Because I think people, sort of like, yeah, I know that. But then when you sort of pointed out to people that, oh, there's a missed opportunity here. And then when people have had one or two good successes, or their colleagues have had a couple of successes, it sort of spreads pretty quickly. So for us, I think really the key piece of not just sort of putting a program in place and being like, oh, this is a good idea, it's really easy to do, let's go ahead and move on. It was really sort of coming back and sort of doing, as Hemel said, analyzing what was going on. And initially our uptake sucked, but then sort of going back and saying, okay, what did we do? And, initially we thought offering funding or payment was going to be enough to get people X-waivered. And we realized that that sort of worked for a certain group of people. And maybe it was because we weren't offering enough money. But we also had to sort of look for other ways to get people engaged, such as giving conference credit, reminding them that this applies towards their recertification, and sort of really looking at the other levers to get people engaged. But I think, for us, it was the two barriers were really actual adoption and getting people X-waivered. And I think from studying, from interviewing, from really looking at our processes, we were really able to use that data and sort of do targeted feedback and offer additional incentives to get people engaged. So, this is sort of a much more simple example than Hemel, but I think also applies that framework. And I think with that, I'm going to turn it over to Annette to help us with a little bit of discussion and to moderate the Q&A.
Thanks, Dennis. Thanks, Hemel. So we have about 8 minutes for a discussion. And so I'm going to start us out with the question, but others feel free to chime in after I ask my question. So you guys touched on this briefly, but the question I have for you, I feel like often as you have something that you want to change within the system, as you go to the department or the C-suite, the first pushback you get is, oh, this is too expensive, or we don't have bandwidth to do this. And I would be curious to hear what advice you have when that's your first reaction of, we don't really have funding for this.
So in my experience, it's more like our internal capacity, like who has the capacity to champion something. I think you do often need a local champion. to move things forward. And so, yeah, funding for their time can be like a tricky thing. Again, like recognizing that Dennis and I both practice in the safety net facilities. For us, the programs I've worked on have again aligned with what the organization was hoping to do. And so I think more than the funding, really, for us, it's been like flow through our system is the priority. So things that support that are usually supported. In terms of, I think there are things that do need funding, and it's important to advocate for appropriate time. So, Annette, if you're wanting to lead something and there's a good idea, like making sure you have time to do a good job with it is important and should be sort of brought into a sort of a project plan and the budget and resources you need for something. At the same time, I think there are ideas that are low-hanging fruit that don't require tons of funds. So like that Meds in Hand project, for example, it's been 4 years. The total cost of giving thousands of people medications for free has been less than $4,000 in 4 years. If any of those result in diverting a potentially avoidable admission, that's 1 to 2 days of an inpatient stay for one patient. And that's, like that program has contributed. So we did get pharmacy to include that in their cost center, but it's such a, like, I think there are some low hanging fruit. I don't know, Dennis, what's your experience been like on that?
Yeah, I think so. I mean, I think you're right. I think not everything takes a lot of money. You can often get started without a lot of funding, but I agree with sort of paying for time. But I think, from my experience, healthcare is expensive, right? There's a ton of money floating around. Someone's paying for this. And often it's sort of about going to the right place for the money, right? Like, for example, if you're trying to, let's talk about hospitalizations and where I currently sit, right? We're looking at hospitalizations. Any avoidable day is $2,000 to $3,000 cash that's being paid out. And who's paying that, right? For the hospital, in some senses, if they're uninsured, that's sort of something the hospital is eating. But if someone has Medicaid, that's sort of $2,000 to $3,000 a hospital may be losing, and they may not be interested in that. But somebody else is paying that, right? The Medicaid insurance company is paying those $2,000 to $3,000, and they are very excited and would be delighted if you told them you could offer housing with supportive services for $300 a night, because that's a 90% discount, right? So even though housing is expensive, $300 a night is not cheap. That's a lot cheaper than paying $3,000. So I think it's sort of about thinking a little broader and outside the box, and not saying, okay, I have to go for a grant. I need to go for an NIH grant. Otherwise, this is not doable, right? There's a lot of other sources for funding, and really sort of going outside and finding those stakeholders, engaging them, and convincing them that your interests are aligned with theirs is sort of my experience of how you get stuff done.
Great, thank you. Anyone else have questions? Feel free to unmute yourself and ask if you do.
Or suggestions for the group, because I feel like part of this is to learn from each other, and there's several people who are leading incredible efforts and have tons of experience. So please share things that Dennis and I missed that have been helpful for your work.
Hi, this is Lori Thibodeau. I just wanted to say I am so impressed with everything that everyone has done. And I think trying to come up with an idea of like how to even get started, I think the way that you guys described things for a novice advocate is really, really helpful, because while I'm sure many of us on the call would like to initiate things, sometimes just looking at, gosh, I want to do so many things, and we just don't even know how to begin. And I think there were so many incredible, valuable points in everything that everybody described. So thank you.
Thank you for that feedback. I think Dennis hit a home on don't let perfect be, the enemy of good enough. And that really rings true for me. These are not, nothing that we presented today is that typical like NIH, perfect RCT. It's just about testing things out and trying to, iterate and do better.
I think you all already touched on this, but if you want to give, each personally what you think is kind of a very common pitfall you see for folks who are very early in the game, that would be helpful.
I think from my perspective, one thing that I see is people getting discouraged, either because the issue seems too hard to tackle or because someone tells them no. And sort of, in my opinion, if it's the right thing for the patient and someone's telling you no, they're probably wrong. And that's sort of a very black and white way to look at it. I know, conversations are often much more nuanced, but I think it does result in that, right? There's a million, if someone doesn't want to do something, they can give you a million excuses why they don't want to do it, whether that be your boss or your supervisee, right? And a lot of those probably have a kernel of truth and aren't outright lies. But I think if you want to make change, you have to sort of be able to navigate that, as we sort of discussed about, and really sort of be able to redirect and really sort of focus on, the goal, the mission, and sort of align with them to think through that. Say, hey, actually, you do really want to do this, right? And this is something you want to do, and these are all the reasons why. And yes, the points you bring up are valid, but this is how we work through those.
I think for me, I'll just speak from my own personal experience of things that I've found hard. So like as an ED doc, like I like to get stuff done quickly. And a lot of what I do does not happen quickly. Like a lot of change management doesn't happen quickly. And while I want to like disrupt the system and make it better or whatever, like that's not reality. And so so in a lot of the work that I've been involved with that has led to sort of sustainable, meaningful change, it's been really slow and chipping away at things over time. And I feel frustrated by that still sometimes. But I think so the pearl there is being willing to look at the long game and sort of chip at things away and taking small bites at a time. You're not going to, it's in my experience, it's hard to completely disrupt things and go from 0 to 60 very quickly. It's about thinking like, what's the next lowest hanging fruit and sort of chipping away is where I feel like I've had more success. And then I think other sort of potential pitfalls are, you want to like erase poverty, like that's the end goal or whatever. And so people, including myself, like you have this, you want to go for this big vision, but you need to think again about what the steps are to getting there and moving in that direction, and making sure that each of those steps does contribute to that long-term pathway. But sometimes when I have seen myself or others get so big picture, then it becomes hard to get started, is what I see, because you don't know where to start. So again, just chipping away, taking the first step, setting goals for this week, this month, this year, and then proceeding after that point.
Yeah, and I think one other thing that came to mind, Hamel, as you were talking, is I think in addition to sort of doing bite-sized, for me, it's really finding your allies. There are people sort of either across the country, even if there's nobody at your institution or nobody in your hospital, there's probably, as I'm sure we'll talk about later, community groups, community partners, other advocates who are working on this. And, even if it's not a mentor in your department, there's sort of mentors outside your department, in your community. And I think sort of really engaging those allies, finding strength in people who aren't telling you this is a bad idea or no, I think often allows you to get over that hump and move forward.
I actually have a question related to that. I'm Dominique. I'm one of the medical students on the call. So my question is, how many people do you feel like you really need on a team when you're embarking on, starting a new project like this? And secondly, kind of what stage in training do you feel like you can really make your own project versus, in the beginning stages, maybe as a medical student or in residency, when you're trying more to identify someone else who's doing work that you could get involved with? How does that transition kind of happen over time?
Great questions, Dominique. And I'll maybe share that because Dennis will be too humble, but Dennis has been a change maker since like before medical school. And so he could speak at length about things that even, so I wouldn't diminish your status as a trainee. Like you have plenty of great ideas. That it is about getting stakeholder engagement and buy-in though. And so I don't think there's a right number for the amount of people on a team. I think more important is that you have a diversity of skill sets, disciplines, people who are willing to support you and also share that, you know, if there are ideas that they think will make things better, and for you to be sort of humble enough to accept their feedback. I don't think there's a right number, but having diversity in terms of perspective and skill is important. And so Dennis, I think it would be great for you to speak about, you know, some of your work setting up the MLP or health advocates. And I mean, you were pretty young in your career when you did stuff like that.
Yeah, no, thanks, Hemel. I think I agree completely with Hemel. I think at every stage of your training, you bring such a valuable perspective. And it's sort of like you think about the medical student on the team, right? They should be the one who knows the most about the patient because they spend the most time with the patient and are really able to dig into the nuances of all the challenges that the patients face that often the resident or the attending don't get to. And the medical student adds such a strong, I think, and valuable insight. So I think in terms of right number of people on the team, I absolutely agree with you, Hemel. I don't think there is necessarily a right number. I think it's really about taking that issue and sort of getting alignment, because I think it's, you know, most of the things, I would say all the things you're working on, you're not going at this alone, right? This is not something that only you see as a problem. I think often many people recognize it, but it seems too intimidating or too big to solve. And I think, you know, one thing that I'll just share very quickly as a resident that I got engaged with was as an intern, I came into where I trained and saw that our social workers were getting obliterated, right, in terms of the number of issues. And there were so many missed opportunities in terms of just helping people apply for public benefits, solving simple problems, because social work was so overwhelmed. They were drinking from a fire hose that they basically just said, okay, here's a list of resources. This is all we can do. We don't have the bandwidth. We don't have the time to help you call. And, you know, no fault of their own, social workers are sort of hugely underappreciated and understaffed at most places. So, you know, I've heard about a couple of different models in terms of patient navigation of resources. So I sort of did my homework, you know, read up on these different models, talked to a bunch of people with experience in these models, and then went to hospital administration and just said, hey, this is something I'd be interested in. I talked to my chair first. He's like, well, let me get you a meeting. And I was like, okay, I thought this was going to be a meeting with maybe a couple of the social workers. I walk into the room. It's the chief operating officer of the hospital. It's our director of social work. I was like, oh, good thing. My mom always told me better to be overdressed than underdressed when I was in a suit and not in scrubs. And, you know, I sort of gave my 10-minute pitch on why this was the right thing to do for the patient, why this would help our social workers out, and that we could probably get some volunteers to help out because there were a number of universities in the area. And they looked at it, they said, this sounds fantastic, let's do it, right? And the head of social work really sort of bought in right away and really sort of helped co-run this effort. And she was like, I've got this intern coming in, it's a medical student who's taking time off between third and fourth year and is doing MSW in addition to their MD. I think they'd be perfect. And, you know, you sort of go from there. And once you get momentum, it starts snowballing. And I remember I emailed all the different organizations in health, interested in health at the local university. And I got exactly one email response back. But that one email response was this person who was like, that sounds fantastic. We would love to help out. And here's a 5-page Google Doc with a project plan. I was like, wow, you know, this is an undergrad who's just like killing it. And we started with about like 20 people. And by the time I graduated, we had over 100 volunteers a semester and sort of funding from the health department to do the project. So I think, dream big, start in standard ways, and, just reach out, and you'll never know. Like I said, there are there's lots of talent out there, lots of people who can do awesome stuff. And sometimes it just takes like connecting the dots and you can run with the project.
Awesome.
That's a very inspiring story. Thank you.
And then Liz, I think I wanted to give Liz a chance to mention some advice as well.
I mean, I think this is kind of building off of what Dennis said, but I think that, yeah, I think you can be of any training age. And I think that's something that can happen when you're younger, is that people are like, oh, you're so idealistic. I wouldn't be discouraged by that. I think that that's okay. Like, that's how we make change. We are looking for something that is more ideal than what we have now. And we're not going to, make any change if we keep doing the same thing over and over again. That's clearly not working or working out well for people. But I think I mean, even still, it can feel a little bit like you're being kind of passed around, but maybe you approach someone who knows something about your issue, and they can kind of help you figure out how one goes about making a certain policy change or instituting a program or what have you at that institution. But I think one of the key things is trying to find like a sponsor who's in some type of leadership position. They may not be on your team, but they can open doors for you and leverage resources to make things happen for you. So like, I had a benefit of having a really supportive chair. We were trying setting up our naloxone distribution program. And he had, I mean, an offhand comment, like, if you ever need any help or any barriers, just let me know. And I hit a cost barrier. And I was like, okay, I have a cost barrier. This is the barrier I'm going to bring to my chair because he can help me figure it out. And he did. Not everyone's going to be able to do that, I think, but like recognizing like who is in what position of power to move like certain levers for you when you need them can be really helpful. Because as a resident, like, I didn't know how I was going to get money to pay for nickel naloxone, but he knew, and he could talk to the CMO to make that happen in a way that I would not have been able to at that time. So figuring out who can really help amplify your message at like certain key points can be really helpful, even if they're not necessarily like on your team per se. And some of those are just like strokes of luck, which is like not helpful advice but I think is how a lot of things can happen. But you can be smart about figuring out where to go. And, sometimes more approachable junior faculty who have some experience, or people who are in admin, but you think are sympathetic to your cause. Maybe they're not like going to be, out there like advocating as strongly as you are, or being like doing the vision part of it, but they can help you navigate the system. And that kind of knowledge takes a lot of experience and time. And so like where you have vision, they might have knowledge of like how the cogs and like wheels work and like who to talk to and stuff like that.
Thanks, Liz. This has been wonderful. We're going to give yeah, go ahead, Dennis.
I was going to say one last quick comment. I think I agree with Liz, and I think one thing is, even if you're not sure where to start, right, I think everybody on this call would be more than happy to help you out and help think through stuff. And, especially emergency medicine's a tiny community. Everybody almost knows everybody. So I think, if you're not sure where to start, the group here, I'm sure, could help you navigate that as well.
We had one last question from the chat that we have some flexibility with time, so I think it's worthwhile addressing.
Sure. Yeah. So, Lori, great question about sort of longer term timeframes around climate health. That's a really important topic. And I'm based in California, so I can speak more intelligently about what's going on here. And I'll just say that this past year, especially since with the fires in Northern California, there's actually been increasing sort of interest from the public health level on this. And so a number of county health officers are prioritizing climate change and climate health moving forward. And so I think, again, part of this is stakeholder alignment to figure out what is going on in your local county public health, trying to align yourself with the public health officer there and see what's going on and where you could add. I think there's probably a topic that it's wildly under-resourced. And so if you're able to bring some of your energy and time and dedication, my gut says you'd be welcome in open arms, and it would be great to align with what policymakers are working towards using a public health framework. That's the extent that I can share, at least from here, knowing that several people are starting to work on this more purposefully.
Great. Thanks for this conversation. And I know all
Thank
of
you
us
so much.
are open to talking more offline, and we can make sure we provide our contact information as well. I'm going to give us a 5-minute break here. And so, feel free, grab some coffee, use the restroom, and we will get started on the next session at West Coast time, 8:08. All right. Can I give everyone a chance to filter back here? If you are joining us on the later side this morning, so as you'll see in the chat, what I asked everyone to do is just introduce themselves in terms of where they are working and where they are in terms of their training, and then specifically any topics that you would like to hear more about in terms of advocacy or activism, either projects you're hoping to get more involved with or topics that you are interested in. And now I'm going to pass off the torch to Hannah and Marie. So you heard from Dennis and Hemel how to do advocacy within your healthcare system. And now you're going to hear from Hannah and Marie how to do activism outside of the system.
All right. Nice to meet everyone. My name is Hannah Janeway. I am a fellow, just finishing my fellowship up at UCLA here in Los Angeles. And I'm joined by my comrade and colleague, Marie DeLuca. I'll let them introduce themselves.
Hey, I'm Marie. I'm in New York City, also finishing a fellowship at Columbia.
So we're going to talk about something a little bit different, something that's not as often discussed in these spaces, and that's about how to strategically try to tear the system down from the outside instead of working from the inside, as Dennis was describing during his talk. I think both are totally valid strategies, and a lot of times you have to be doing both at the same time. However, physicians and healthcare providers in general have been not as good at doing the outside strategy as trying to do the inside strategy for a lot of reasons, right? Because we're rewarded for taking the inside route when we're not really rewarded for kind of going along the outside route. And so rewarded, I mean academically and officially or formally. I think you're probably rewarded in other ways for working from the outside. So we're going to talk a little bit about how you can expand your activist toolkit so you have other methods and methodologies to use if you do want to tackle an issue, because not every actual issue can be tackled most effectively from the inside. And so we're going to kind of use our own personal experience, but kind of as they were talking about in the last talk, both Marie and I are pretty insistent on the fact that, hierarchy does not help creativity and really is pretty destructive in the process of trying to create change. And so certainly if anyone has ideas or disagrees or, has some strategic knowledge about any of this, feel free to jump in. I mean, this is really a space, workshops in general, I love them because they're a space to learn and they're also a space to share ideas. And, every time we do this workshop, I feel like I learn something or get a really good idea from at least every single one of the participants. And every time I'm like, oh, wow, I've never even thought of doing that before. So please feel free to interject and also feel free to add your own expertise. It has nothing to do with levels of training, just has to do with your levels of ideas. So, there's a lot of stuff that goes on in the outside world that affects everything that we do inside of the hospital and affects health in general. And I think we all know, since we're all here, that those things actually probably affect a person's health more than any one thing that happens in our clinical care or clinical scenarios. And over the last, 4 to 8 years, I mean, I can name a whole slew of events and a whole slew of things that are happening out in the outside world that have really forever changed, how our patients experience the world. And these are just some of the visual representations of that. Maria and I started first, working together actually around issues that had to do with the US-Mexico border and asylum seekers. And some of the things that we are going to talk about during this talk, we're going to kind of reference back to a direct action that they and I planned in late 2019, where we did a strategic action down at the US-Mexico border, a series of them, one of which resulted in our arrest for a purpose. And it actually had one of the outcomes that we desired, not all of them. So we're going to be referencing that throughout our talk. So, why direct action, right? So, I mean, I'm sure you guys have heard or been told a lot of different strategies about how you can do things. So someone might be like, oh, there are children in encampments in prisons, essentially, at the US-Mexico border, and you want them to be vaccinated against the flu. And why can't you just write an op-ed, or why can't you just write to senators or to other individuals and get that taken care of? And the reality is, before we did a direct action, we also did all those things, and none of those things worked, but they also helped us for our PR campaign later on when we did the direct action. But sometimes, you don't have enough power just writing an op-ed. An op-ed really doesn't risk very much, and strategies that don't really risk that much privilege, as we'll be talking about later, a lot of times are not super effective in creating change. And so in addition to, doing things like social media campaigns and writing op-eds and, working inside hospital committees, sometimes you do need to move beyond that and do something like direct action in order to create change. And why is direct action so powerful? I mean, I think there's a lot of examples in history, but I think it really asks, like, what side are you on? And it displays the issue in a way that shows the stark contrasts and the moral and ethical boundaries between what you think it isn't working and what you think might work. And so here are just some examples, like everything from like the Montgomery Bay bus boycott to the March in Selma to the Boston Tea Party, where they threw tea off a boat, which was a very powerful act of actually direct action that really targeted something economic, to protest during the Vietnam War. Those were all direct actions. And actually, one of the things I like to point out to people is that these are methods that, while physicians and healthcare providers haven't engaged with a lot, there is a long history where they actually have a minority of doctors and other healthcare professionals have engaged with that throughout history. It's just not a history that you have actually been talked about, but it is a history that's there, thinking about back to New York City and the Young Lords, et cetera. But, basically they're powerful because they visually illustrate to people how you can come together and stand up to those in power to bring on needed changes. And like I said, I mean, these are pictures from our protest that we did down in San Diego at the CBP headquarters. And here are two of our colleagues who were arrested with us. And it really asked, what side are you on? Here you have two large military men in their full outfits with their helmets on, and they're arresting, our friend Mario. He's in his white coat, and a comrade of ours who works in a Jewish organization, and who's singing this beautiful Jewish song, and they're arresting us for asking to bring vaccines to children. I mean, it really does paint a very powerful image. So what are the benefits of direct action? I kind of went over this, but it draws attention to the issue. it's a demonstration of numbers and force. It disrupts business as usual, which is a really important component of direct action in general. It builds community and creates a vision of what a better world will look like, and it allows organizers and participants to meet one another. And I think that's one of the most important things. And then plan new actions for the movement. So it brings a bunch of people together who might not have collaborated before. Matt, who is, this Jewish activist, I had never met with him. And now we've done several actions together since that time, because he lives in Los Angeles. And so we've come together and been able to plan and do actions together subsequently, whereas I would have never been able to do that before. So, when you're faced with some sort of injustice, something's going on, your patients are being subject to ICE raids, or, there's, police violence against the communities that we serve, how do you kind of combat these justices with direct action? And I think one of the first things that you really need to do is, and this is not a step that necessarily we're going to talk about when we're talking about every single direct action, but I think it's a really important personal step, is I think first you need to be like, what is actually causing this oppression? Because it's super important to keep that in mind when you are thinking about what sources of the oppression to target. So we're going to talk about how you select a target, but also just because you have to keep in mind the larger picture. You can't get bogged down in the small details. And so if you're talking about the border, for instance, we were specifically strategically protesting against the fact that they weren't giving migrants vaccines. However, that is not that is not the big issue, right? The big issue are borders themselves, are the oppressive forces of capitalism and, colonialism and imperialism that have allowed for this inequity where some people have the freedom to move and stay and some people do not. And that lack of freedom to move and stay has caused great oppression on people. And that's also important because, when you're talking about something like, for example, borders and border abolition, one of the big points in all of that is, as physicians, we kind of get bogged down on, oh, we need to help asylum seekers. But really what we need to be saying is we need to help all displaced people, because when you start breaking people into the categories of those worthy to get across the border through our mostly biased opinions, and then those who we deem to be not worthy because, say, they're moving for economic reasons, you forget about the fact that the same structural and oppressive forces that stop people from, or that cause people to move because of violence, are the same exact ones that cause people to move because of economic violence. They're one and the same. So really, we shouldn't be artificially separating these individuals. And so it's good to keep that in mind when you're planning these actions, so you can try to highlight those sort of dichotomies in your protest itself. And then your overall strategy is that you really just need to identify your group's power and then find a specific way to concentrate it in order to achieve your goals. So, one of the things that Marie did and that I have done is you have to go through, essentially these series of questions in order to decide what are the tactics that you're going to use to create change. So what are the goals for your movement? What are your desired outcomes? Who has the power to give you what you want? How can you put pressure on those people in power? And what can you accomplish without mediation by those in power? So trying to really equalize power in these scenarios.
So a useful way to break things down, once you have an idea of your strategy, so you've gone through those questions, the next thing to do is to pick a target, pick a point of intervention. So the points of intervention are a way to think about the different places that one can intervene to effect change when harm is occurring. So a point of production, for example, is usually like an economic target. That's, for example, let's say there's a factory and they've been collaborating with ICE to allow the imprisonment and deportation of their workers. So one way that the workers then could apply pressure is by strikes, picket lines, or some sort of factory takeover. A point of destruction is the place where harm or injustice is happening. I think a great example of this would be detention centers or prisons. They're often in places that are much less visible to the public. They're hidden from sight. And tactics there could include blockades. We see this frequently when we're looking at issues of economic justice with pipeline blockades. A point of consumption is a place where people are interacting with a product or service. So for example, if we take that factory in the first example that has been reporting their workers to ICE in retaliation for union organizing, then a store that's selling those products to the public could be a good point of consumption. Consumers could choose to boycott that store because they're collaborating with a factory that's harming their workers. And that could be one way to enact power. A point of decision is the place where people who have the power to act are located. So that could be Congress, that could be Customs and Border Protection headquarters. And tactics like this could include something like meeting disruption. And then a point of assumption, this one is a little bit more, this one requires like a little bit of thinking about it, but essentially it's a place that builds the ideology of problematic systems. And I think a great example of this is the border itself, and specifically the physicality of having a border wall. It's taking this invisible line that creates a lot of harm and a lot of pain and control over people and makes it a physical reality. And so the border wall is really a good point of assumption. And tactics here are really focused on highlighting the unexamined nature of these beliefs and calling attention to it. So looking at the wall and saying, well, why does this exist? And is it actually real? Or is this something that we've created to maintain an ideology that's harmful? Once we've thought about our points of intervention, that's when we can start thinking about tactics. In the next couple slides, we're going to look at a couple of different tactics. But one thing I want to highlight here is that when we're thinking about actions, we often want to start with the tactics. So we're like, let's have a protest, right? And it's like, okay, but what is the point of the protest? So that's why we want to start a little bit further back, as Hannah did, looking at the overall causes and then looking at the strategies that we want to use, finding our point of intervention, and then fitting our tactics to that point of intervention. There's a couple different sort of categories of tactics that we could think about, and these are all just sort of ways to organize things in your mind, but they aren't hard and fast rules. So protests, an example of protests are basically anything that's speaking out or being vocal about dissent. That could be marches, that could be letter writing, that could be petitions. Those are all acts of protest. Then we have non-cooperation. That's essentially withdrawing from a system to prevent it from functioning. So strikes, boycotts, a lot of labor organizing will use non-cooperation as a really powerful tool. Intervention is when you directly prevent a system from functioning. So blockades, blocking streets, disrupting meetings, all of these are things that prevent the system from enacting the harm that it's doing. And finally, we have creative solutions. That's when we build community-based alternatives so that we completely subvert the system that is creating harm. For example, if we're finding that there's a lot of economic discrimination within hospital systems, there's systems that are not allowing people who don't have insurance to receive care, we can create a free clinic and say, you know what, you want medical care, we'll give you medical care. We're not going to ask for your documentation. We're not going to ask for your insurance information. You can come and we'll care for you. Another example of this would be community gardens. If people don't have access to the foods that they want to be eating and the foods that are healthy for them, they can choose to grow those foods themselves and distribute them to their community. I picked this picture of one of the examples of this at the border, which is a set of seesaws that were installed between the border so that children on each side of the border could play with one another. And I think this is a really beautiful example because it's both a creative solution, it's providing something for the community without asking for mediation of the people in power. And it's also a great example of that point of assumption, of going to the border wall and breaking down that idea and saying, well, we've got children on each side, they want to play with each other. And the only thing that's standing in their way is this wall. And why do we even have it there? Blockades have been a really powerful tool. And I think what's interesting about this is you can have a number of different types of blockades. So you see the picture on one side, we have a physical blockade, which is really just like barricades that have been built. And you'll see these in protests in the United States as well. We saw this throughout the summer. If you have a group police force that's attacking you, one thing that sometimes becomes an important protective measure is to build a barricade to prevent that force from getting towards people and beating them. It's also a way to disrupt functioning. So you see the environmental activists have used this really effectively. Here they're blocking a driveway. And what you see is that they're using their own physical bodies, and they've actually attached themselves to heavier objects to make it very difficult to remove them. So they're becoming a human blockade, which I think both is physically disruptive, and it's also in a point of really intense vulnerability, to be using yourself physically to lock yourself to a heavy object and say, you can't drive through here because I'm here. And if you do that, you're going to harm me. And so there's, I think, a lot of power in people doing that and using that as a form of blockade. And then you have essentially people standing in a line. And this can be a really simple and effective tool. This is what we used when we went to the border. Is we just had people essentially lying in a driveway, and you can't drive through the driveway without driving over the people. And so we disrupted the operations of the Customs and Border Protection headquarters in that area for a couple of hours while they made their decisions about whether or not to arrest us. Street art and theater is also a really important component of activism. Art is what makes a revolution irresistible. And so when we look at the physical harm that's going on, sometimes it's hard to visualize. We hear news stories, we see things that are really painful, and to connect and humanize with it, it's often helpful to have some kind of visual reminder. These are really good displays to do in places where it's a little bit removed from the point of destruction, from the place where the harm is happening. If you're going to DC and you're trying to talk with if you're trying to lobby lawmakers about what's happening, it can sometimes be good to give them a reminder of what exactly they're passing laws about. Perhaps it's the deaths of people from COVID who have not had access to medical care and who have been, disproportionately affected because of the systemic oppression in our society. Oftentimes when we talk about passing laws allowing Congress to declare war, then people start to talk about like the idea of like blood on your hands. And so we see a fountain of blood in the bottom corner. And so I think that street art and street theater can be really powerful displays, and it not only targets the people who are making the decisions, but also the people who might be voting for those people who make those decisions. And it helps the rest of us connect to what's actually happening and to understand why we need to be taking action. When we're talking about taking these actions, it's important to think about our own positionality in terms of privilege and oppression. I would say that everyone in this talk, in this workshop, has some amount of privilege in that we are all medical professionals, we're all physicians. And many of us have different types of privilege and are experiencing different kinds of oppression. I'm a white person, so I have privilege around race. I'm also a femme person and a queer person, and so I do experience oppression in those lenses. When I go to work, I work primarily right now around issues of prison abolition. So abolishing prisons as they're one of the main injustices and causes of harm in our society. And when I'm going to that work, I'm going to work in a legacy of literally more than 400 years of work around Black liberation. And so if I'm showing up there, I need to show up in solidarity and not think of myself as a savior. I'm coming to this work late. It's been going on for 400 years. And so when I'm going to that, I'm thinking about how to center the voices of the people who are most affected, to follow the leadership of the people who are most affected. All of the movements for liberation are intertwined. As a queer person, I know that my liberation isn't going to happen without the liberation of all people. And so if I'm working for my own liberation, that means I need to uplift movements around me. If you're interested in environmental justice, environmental justice and racial justice are inherently linked together. And so when you're doing that work, you're also doing work within other movements and uplifting other movements. Change only occurs when you're ready to risk your privilege. And it can feel, risking privilege can feel like you're losing something, but in reality, you're supposed to lose privilege. Like, privilege is not a good thing. It's sometimes something that we sometimes leverage to provide like quick safety. So maybe you have a patient who is experiencing something and you realize that as their physician, as their advocate, you can use that privilege to support that person. So you do it in that moment. But the ultimate goal is that you not have disproportionate power over other people. And so when we're talking about taking these actions, we need to start practicing what it feels like to risk privilege and to lose some privilege if we're going to actually move towards a liberated world. When you show up to street actions, you may see people taking actions that you're not comfortable taking yourself. That doesn't mean that they're bad. I think that this came up frequently when we saw demonstrations over the summer and there was property destruction, and property destruction isn't violence. Property destruction is destruction of property. It's not people. And when we see people doing that as expressions of grief, as expressions of reclaiming political power, that's something that I know that I'm not going to try to interfere with. That's not my job to tell other people how to practice their politics and how to pursue their liberation. I think when we think about direct action, one of the questions that's come up for both me and Hannah frequently, doing these actions, talking with people who are joining us in these actions, and also doing these workshops, is the idea of risk. And yeah, taking risks is pretty scary. It's something that we actually do all the time as physicians. I think if we think about the work that we do in the hospital, I'm sure every single one of you has a moment you can think of now of a time when you saw a patient who wasn't getting the care that they needed. They weren't getting the support they needed, or they're experiencing active discrimination by your colleagues. And you thought about what was going on. You understood that there were significant risks to the patient because of that. And then you probably also realized that there were risks to you. Maybe you were a medical student, you saw a patient who was experiencing discrimination. Maybe that discrimination was coming from the attending or a resident whose, evaluation of you was really important. And in that moment, you decided that that risk was worth it because what was happening to the patient was unconscionable. And I know in my training, I was often told by when thinking about medical decision making that we need to make the decision such that we can go home and sleep at night. And that carries through into our interactions with social emergency medicine. We need to take risks such that we can go home and sleep at night. So we take these risks in the hospital to support our patients, to be the best advocates that we can. And sometimes we find that the processes that are affecting our patients started so long ago and we can't affect them in the emergency department. And I think that's what drives me to go outside the emergency department, to take direct action, to work as an activist outside the system. I feel that our jobs expose us to a significant amount of moral injury because we are operating in that safety net and we're watching as the safety net fails to catch people. And we're participating in that experience of not quite catching people, of seeing someone who's had significant harm from being unhoused, from struggling with substance use. And we just aren't able to do enough for them. And so when I'm able to go outside the system to support that person, to work alongside that person in their own support, that helps me, in addition to feeling that is like a necessary thing as a person to do. It also helps me with the moral injury that I've experienced in my job. When I weigh risks about a specific action, I try to do some research. So I try to understand, like, what are the medical licensing risks if I'm arrested during a protest? And then I also try to build, as previous folks have talked about during this workshop, I try to build allies and relationships with people in my workplace so that I know that if I start experiencing some kind of like political repression, there's people around me who would support me and support my political work. And then I think about the risks of the people I'm working alongside. And the reality is that I will never be at as much risk at a protest against police violence as the 19-year-old Black kid who's standing next to me. And that person is taking those risks, and they're taking more risks than I am. And I think it's important for us to acknowledge that when we think about risk as physicians, oftentimes the things we're risking are not as severe as the things that our patients are risking, or that our communities are risking, or our families or friends or loved ones are risking. I also think it's useful to ask ourselves, how do we move towards a place where we're more comfortable taking risks? And for me, that's a gradual sort of stepwise process. I think about things that I'm not comfortable doing right now, and then I try to imagine what a world would look like that would cause me to be comfortable with that. What would have to change? And how would I know when I'm living in that world and I'm ready to take that next step? So what we're going to do next is we're going to think about, sort of brainstorm a couple ideas, things that people would be interested in workshopping. And then we're going to break out into breakout groups and essentially plan actions together. So what I'd love people to do is in the chat, name some issues that you'd like to potentially work on. And then we'll pick 4 of those, and people can split out into breakout groups, and we have a little worksheet for people to work through to plan actions together. After that, we're going to come back together and we're going to hear about what you all have planned. So what would people be interested in working on? I would recommend, when you think about these things, you'll probably initially think of a really general idea, and then try to make it like a little bit more specific. So if you're thinking about environmental issues, you might start with climate change, and then you might get closer in and say like, oh, like a pipeline. And then you can kind of like workshop an idea around a pipeline. All right. So we've got a couple issues in the chat right now. We've got housing, we've got line 3, post-incarceration employment. And definitely keep throwing things out. We're gonna pick like probably 4, but there's no bad ideas. K-12 education discrimination, children's health and detention centers, behavioral health in the emergency department, especially around restraint use. Yeah, that's a big one. Climate health education for students and resident attendings, and maybe lawmakers who have a little ability to understand the science since they're business focused. So what I like is we can do a quick sort of voting so we can pick our top 4. So of the things that have been listed right now, if you'd like to be in a group discussing that issue, can you please just put in the chat what you want to discuss? Treating patients that are experiencing homelessness in the ED.
Maybe what we can do is break people up more into like larger sort of categories. And then you can narrow it down inside of the group. So the categories maybe would be education, incarceration, environment, and
Housing.
maybe, yeah, housing.
Okay, yes, let's do it that way. Okay, so we're gonna have 4 working groups: education, incarceration, environment, and housing. And everybody can choose their room. So room 1 is going to be education. I'm going to name them. We're
And
going
the
to.
purpose of this is really so that, you know, to talk about this sort of thing is only so useful. Part of it is learning how to go through the process so that, you know, wherever you are, you can go through the process on your own to plan an action in the future. So it's an exercise, but it's also a really great way to get good ideas from other people in terms of some really creative stuff that you could potentially do.
And Hannah and I are going to float through the groups. We'll put a link to the Google Doc with the worksheet questions in each group chat. And we'll float through it to see if folks have questions or want to discuss things. And then when we come back in 20 minutes, we'll discuss the ideas that we've come up with. So go ahead, pick your favorite, and we'll see you in a few minutes.
So I think I have to close. Hi, this is John. I'm your IT intern from SAM. And I think I have to close all the rooms and then restart them and then allow you to self-select the rooms you want to go into. So let me do that.
Okay.
I'm gonna close the rooms. Oh.
It takes a minute.
And then
Okay, so you can do it in 50 seconds.
Okay, here's the link for the document that should help you guys think about these things.
I have to wait. Okay, we have to wait until the breakout rooms close and then I'll reset them.
Sounds good. Thank you for your help. We appreciate it. Annette, when are we closing this particular session?
We have until 9:30 West Coast time. So another 45 minutes.
Okay, great. Okay, cool.
And we have some wiggle room, so if we need more time, we certainly can use it. So we are getting the breakout room set up again. So give us just a minute here. Thanks.
One other thing, you know, while we're just sitting here looking at each other on Zoom, was that awkward moment. So one of the things that has come up a lot, I think, for both Marie and I, and they touched on this, but is I think a lot of people have said to me, oh, you know, it's really great what you do and I admire it, or I really appreciate it. But, you know, I just could never do that. Like, you know, there's something special about you that makes you not scared of doing these things. And I just want to reiterate to everyone that, you know, there's really nothing special about us. I think it's just going through these mental processes that Marie was discussing. And every time I go out there and I risk privilege, it scares the crap out of me too. Like, I mean, going and standing and saying no to a large militarized police, even though I have a ton of privilege that allows me to be fairly confident that I will be safe when I do that, that is scary. Like, I am terrified. And you know, I think it's important to acknowledge that only because I think that there is this, people look at activists or people who are out there doing these things and they kind of put those people in a different category than themselves. They like kind of other those people in order to create sort of a cognitive dissonance. Like, I've done this too, so that's how I know it exists. And I think, you know, I just encourage people, for me, it was really about trying to find that internal courage in myself to do the right thing, even if I was scared. And just acknowledging, yeah, I'm scared. Like, this is a really scary thing in this society. And even though I have a lot of privilege, I still can be scared, and it can be really brutal to be arrested. And, you know, even, you know, and there are things that you're going to lose or miss out on. Like, you know, you might miss work, you might miss out on family, you might be in jail, you might get written to by your boss, you might lose your job, these are all things that you have to consider, and you can plan in advance to see how much it's going to affect you, which can be helpful. But at the end of the day, it's always a little bit of an unknown. And so, that self-work is really, really important. I think that's what's really helped me.
All rooms are not open, so please go choose your rooms.
And then you have to go in one of the rooms to record.
Yeah, thank you for that, Hannah. I echo all of that. Like, all activism is done by regular people. So all of us. All right, breakout rooms are open for folks who just joined. We're picking one of 4 breakout rooms, which are just organized by issues that people are interested in talking about:
Yes.
education, incarceration, environment, and housing. So pick whichever room you'd be interested in. And then once you're there, people are going to work through a worksheet that helps to think about and plan a direct action. Then we'll come back after 20 minutes and discuss the actions.
Click on breakout rooms and select.
So yeah, breakout rooms are open. Everyone can go ahead and join. If you are looking, it's the little box down at the bottom. It looks like 4 squares.
To everyone.
Yeah. Which is where?
There's a little box that says breakout rooms at the bottom.
There you go.
That's where you can select your breakout rooms.
Select breakout rooms in the bottom of the bottom corner.
And Hannah and I will be coming through briefly to put once everybody's in their rooms, to make sure that y'all have the access to the worksheet.
Oh, someone can't join. When they click, okay, so you have to click, I think you have to.
Aislinn, what room do you want?
Yeah.
We can
put
just
you in a
assign
room.
you to it.
Okay, Kristen, I'm gonna put you in education.
Perfect.
If you hover over the number, it gives you an option to join, like the number of people in the room.
We know wants to go to
Yeah.
housing.
The choice has disappeared. That's the issue.
Oh.
So there's
Don't
nothing
worry,
to
I'll
click on.
get you there, Brina.
Thank you.
No
Yes,
problem.
Dennis. Tech support, love it.
Yeah, sorry, I'm in the same boat. Sorry to be another tech.
Okay, where do you want to go?
Education, please.
Education, we'll get you there.
Thank you. I appreciate it.
No problem.
Anybody else looking for?
Where does Annette want to go?
Yeah, I was going to ask, is it helpful for me to be anywhere in particular?
They look pretty evenly split. Environment has the fewest. Just pick whatever you like.
That's fine. I think I might be able to add myself, actually. I'll go to environment.
Okay, cool.
Let's see.
And this education for Jonathan, Don.
Hey Dennis, sorry, I don't know why it should choose to let them choose on their own. I'm not sure why it's working.
That's okay. It works
Is one
out.
of the presenters staying back in the main room?
I'm gonna start going and dropping the
Yeah,
work.
you guys should go into different rooms. I can stay in the main room.
Yeah, we just
Okay.
need one of you to stay in the main room because we have to go into one breakout room and record for CME purposes.
Okay.
Okay.
I'll stick around.
All right.
Nancy, do you have anywhere you want to go?
Environment.
And Michael.
They might be absent.
Hannah, I'm gonna go to education and incarceration and put the worksheet in. Okay.
Okay, I can go to the 2 other ones.
I'm
and put
gonna
it in.
assign them to a place then. There we go. Perfect.
Conceptualize what, what it means, why this is a problem.
I can't hear too.
Yeah. Sorry.
I can't hear you.
I know, that's
Oh,
why.
there.
Plug.
There. So and the problems are very difficult to link to show, so that the lack of education and understanding about science and the distrust of science and scientists makes it even more difficult to show, like a lot of the lean things that were shown in the last session were phenomenal, fantastic, but it's a lot harder to go to your chairman, to go to the Vice Dean of Academic Affairs and say, hey, I want to create this program teaching at least, our community about climate health and why it's important. So at least our folks will listen because we understand science. But as you mentioned, it's really, really important that we get the people making the decisions to understand it too. And so I don't know how to go about doing that. I can do my small part by trying to bring climate health to my institution, which is my first step, I think. But I also feel really uncomfortable because I feel like we have an opportunity to teach a larger population.
I think this gets at the difference between the advocacy and the activism point, though, because like within the institution that we all work in, like I can advocate for that change, but that's going to be limited to the institution that I'm at. If we're talking about addressing something as big as climate change, I think we have to get into the activism mindset that this isn't going to be something that we're going to be able to fix from within a hospital, for instance. We can certainly use our position as doctors in that hospital system as advocates to like lawmakers about things like pollution and asthma in kids. Like we can definitely leverage it, but I think we have to step out of our idea of doing this all from within the institution. That's where we're comfortable, and I'm not even very comfortable doing that. Right. To be honest, I'm not like, I would love to be more comfortable doing that, but I'm not. But I think that's something that we have to do both when it comes to something that this complicated. I don't really know that there's a way to do this purely from an advocacy standpoint or purely from an activism standpoint. I think we need people doing both, and it's hard to do that.
Have you guys thought about what more narrow of a topic you're going to do?
I think the one that I come up with is how much freaking waste we use in the hospital. Yes. We don't even have recycling cans because we tried them and they ended up filled with gloves. Yep. Because they were in like the same space. And so we tried having recycling cans and it lasted about a month, and they realized that what ended up in the recycling can, because it didn't have a lid, was all gloves and things that cannot be recycled. And so the only place that there's a recycling can is in the staff break lounge, which is like half a football field away from where I sit in the ED. So it's just never, like nobody's ever going to recycle and you have to walk that far. Like that's just never, we know that that's not going to happen. And then you get into like, yeah.
So so basically your goal for your action that you're going to plan is to reduce waste, to pressure the hospital to be more active in reducing waste.
There was actually an article in Academic Emergency Medicine, I think a few months ago, on the amount of waste that emergency departments create. And then one center, I don't remember where it was, took an active role in reducing waste. And they showed not only a huge amount of reduced waste and recycling things, they also repurposed or somehow sterilized things like low pros, or I'm not sure what, I don't remember the details, but they also saved money. So that might be.
So maybe your goal is like for just the purposes of this exercise, your goal is you want to reduce waste, and your hospital or whatever, your county or wherever it is that you're, whoever you're trying to pressure to reduce waste, all of hospital systems, it doesn't really matter. But you're trying to pressure them to create more waste reduction than they already have, right? So that's kind of your overall goal. So then you have to be like, who, literally I go through this every time I plan it, like a protest or a direct action. Then I'm like, okay, who's going to give me what I want? So if it's like my hospital, so like there's been times when my hospital, the hospital system that I've worked at, I'm like, I brought these things to them, but they're not doing crap. They're giving me a bunch of like things that aren't working, and no one seems to be particularly motivated. And this is a really important issue. So I'm just going to leave the hospital system and I'm going to pressure them from the outside using this other strategy to get them to do what I want. So I go like, well, who has the power to get me what I want? Is it like, so in LA County, at a county hospital, for instance, I might be like, oh, it's the board of supervisors, you know, or it's the CMO of my hospital, or, you know, it's my boss. I mean, whoever it is who you're like, this is the person ultimately who has the power. So I can tell you, like, you know, some of the stuff that I've done around police violence, I've ended up being like, it's actually the board of supervisors who controls the budget, who's going to be able to determine whether there's police in hospitals. Like, I'm going to stop talking about this to my CMO because he's just a pawn, you know, and I'm going to go back up the line of command and say, who actually has the power to create change? You know, it's the people who control the budget. So with this exercise, what I would do now that you guys have identified, I guess your goal, which is to reduce waste, I would be like, who has the power to give me what I'm doing? And then I would go, you know, what type of intervention, what's the point of intervention that you want to go about for this? As we discussed, there's like a bunch of different points of intervention, right? That you can use to tackle this issue. So, you know, there's points of production, right? So that's like, you could tackle the place, say you're really unhappy about, I don't know, styrofoam cups in your hospital. You could tackle like, you know, the factory that produces styrofoam cups, or, you know, point of decision. Like, you could go to, say, if it was the board of supervisors, you could go to the board of supervisors office and create a huge trash mound of all the trash from one day at your hospital in front of their office, you know? So these are the things, you know, you have to go through, but you have to pick out what point that you want to intervene at, and then plan something, whatever it may be. It could be, you know, like just art. It could be a protest. It could be, you know, just a media event. Where you're displaying this to the media. The reason Marie and I's protest work when we got arrested is because it was recorded by many news sources, and then it was retweeted like 4 million times. And so that's what helped our cause. That's how we ended up in Washington, D.C., talking to the head of CBP. So these are the things, you know, try to work through this through the worksheet. Do you guys get it?
Yeah, I have it open.
Try to see what you can come up with. I'm sure something super creative. I'm excited. But I'm going to jump to another room. Do you guys have any questions?
Just where is the worksheet? Sorry.
Oh, yeah, I put it in the chat. Can you guys still see the chat?
Yeah, we can.
Do you see that Google Doc?
I could share the Google Doc on a screen if that's helpful for us.
Yeah, that'd be great.
Let me see.
All right, I'll be back.
All right, can you guys see the Google Doc?
Yep.
Great.
I think everybody is using the same Google Docs. We aren't going to be able to type in
Yeah,
those.
yeah. I can, I mean, we can make a new one.
Yeah, make a new one.
Right. I will mainly work here on kind of documenting what we're talking about. So feel free to start spitballing.
Can you just share the link to the new Google Doc as well? Sorry.
Yeah. I mean, if it's easier, I can just keep the screen up and type as we go so that you don't have to worry about.
Yeah, I think that's going to be easier because you're going to have to share it with individual people, I think, usually.
Yeah. Yeah.
Once it's a restricted link, like it gets complicated.
Okay, never mind.
And it looks like it's a locked document. So I think like I just brought up the idea of the waste idea is just something that annoys me on a daily basis at work.
Yes.
But there are certainly other ideas that we could think about for it. So I think, what other goals do we have? Like, could we maybe have? Other ideas could be things like trying to get more like solar energy or wind energy or something like that as a source of energy for the hospital, considering we definitely use a lot of power.
I think my hospital just this year is looking into using a new company came into our area that has a solar farm. So it's not like putting solar panels on top of individual
Right.
roofs and things, but the hospital is not only looking into using them, but also giving discounts to employees who use that. So that's
So, I mean, I think that's
something too.
certainly a viable possibility, like something where we're kind of using the fact that hospitals tend to be massive employers in a community where they have a lot of employees, they themselves are using a lot of power. And so I think getting the hospital to leverage that, I think, is certainly an option. I mean, it might be more effective than the reducing the waste idea. So I think I think I actually like that idea a little bit better than the reducing waste. What do you guys think?
I'm on
It's
board.
interesting. Things that I was kind of thinking about that were outside of like the health system specifically was like line 3 is a huge timely issue that has direct action planning around it. I don't know if anybody's familiar with line 3. So I don't know if there would be an opportunity to collaborate with the current direct actions that are planned, probably more so than restarting one from the ground up when there's already a lot of planning around it. Something else I considered is reaching out towards your broader community to try to advocate for like a city to create a commitment to going net carbon neutral. You could do that within a health system as well. You could advocate for your community to create like a heat wave response plan. Heat related illness is the #1 weather related killer. So making sure that there's sufficient mitigation strategies, cooling centers, things like that.
Ooh, this is really
like that
interesting
one.
to me. I don't know very much about it, and I feel embarrassed that I don't, but I'm a bit of a novice, but I'm very interested in trying to help. And that sounds like
I really like the idea of the kind of community centered approach. So like making your community, including the health system acting within that community, net carbon neutral. And then that also comes into, if you're going to do that, you also as a community have to figure out like how climate change is going to affect your community. And so planning things like cooling centers where homeless patients can go, where when it's 100 degrees outside, kind of making sure the community stays safe. I think that's one option. I think the mitigation strategy is about like mitigating climate change, like the carbon sink idea. I don't know if we know how to do that yet.
For the purposes of this exercise, we should pick one and see if we can run with it, just so we get some experience with our direct action plan.
Okay, sorry.
And that's kind of the issue, is that there's so many different ways to do this it's easy to get stuck.
Which is kind of the point that Dennis and Himmel were talking about. I think it's easy to get, don't let perfect be the enemy of the good, right? It's so big and broad. Do you guys have a sense of which kind of specific issue, either reducing waste or alternative energy sources, or, heat mitigation and cooling strategies probably make the most sense, one of those 3?
I personally like the idea of the alternative energy source, like as a part of a larger goal for net carbon neutral for a community. And so we can use as a way to leverage the hospital as like a large employer. In a community and kind of use that to get the community to shift as well. I mean, I'm in California, so it's a bit different here because that's something that's like it's a pretty widespread goal already that I think a lot of people would buy into. So it'd be a bit different for me to be working on that than like where my parents live in Central Illinois.
Well,
Yeah,
I'm in New
different process.
York, and if my hospital is like even considering it, and we don't get a lot of sunny days
Right.
compared to California. And so I was shocked that my hospital's considering it. So
I
that's
mean, they're considering it
positive.
because it overall ends up being cheaper, actually.
Oh, everything has to do with
Yeah.
the bottom line, I'm sure.
And so I think that's part of, okay, so we'll say we're focusing on alternative energy sources is kind of our goal. And so with the idea of eventually moving towards net carbon neutral and kind of using this as kind of a way to initiate that process. So who has the power to give us that? If we're talking about the hospital, I think it's CMO, potentially, depending on public versus private, it might be something like county level if it's a public institution. If it's a private institution, there's going to be like a board of directors. Either way, I think money is the way to do this. Like, I think bringing up the financial impact is going to be the way to get anybody with those kind of titles to pay attention.
Right.
And so I think some of the finances, we have to also include things like cost of healthcare by not doing this. So increased pollution from coal-powered power plants, for instance, leading to sick days, missed work from parents having to stay home or take their kids to the doctor. I think it gets to be more of a complex story. And then you also get more personal impact statements from a family that lives near a power plant, which gets to a much better conversation.
And so I think there's a lot of avenues that we could take within advocacy of trying to work within the system, both within our hospital and policy. But to kind of the example Hannah was giving earlier of if we were to go at this for more direct action, what would be kind of what point of intervention would we want to use to approach this?
I love the trash outside.
I know. That was kind of beautiful, wasn't it?
That was just priceless.
And just the amount of trash we do after like one trauma case.
I know. Like, have you ever walked by the trauma room after they're already in the OR or in CAT scan and just all the crap on the floor?
Yeah. I think for something like this, one option is picketing outside, like kind of doing something right outside the current power plant and kind of making that visual.
You could do like a die-in at a power plant to show the health effects of fossil fuels. Unless you got sufficient media attention, I don't know if that would really translate between what your action is and the person who has the power to make the decision to make that change. I don't know if this would be feasible, but a translation to putting the trash outside of their office is like bring an internal combustion engine, just like sit it outside and like, this is what you're spewing to fuel this hospital. and now you're the one that has to breathe it instead of the frontline communities.
I love that.
I think visuals, so like like I'm picturing like early on in the pandemic when like everything just shut down and there's no smog kind of thing, like something like if we could get like a visual related to that, related to like if their power plant was shut down for a day, what the air quality looks like compared to when it's not.
I think the idea of the visuals here are really powerful. I'm just trying to think how to capture them in a way that you can bring it to someone's doorstep.
Yeah. You could also think like protests outside Board of Supervisors meeting kind of thing, like, or a county board meeting if you're doing a public hospital. Because especially if we're looking at this as like kind of a net carbon neutral goal for a community, it's going to have to come from either county, city leadership, something like that.
And
so
maybe the
kind of-
visuals can dummy it down for them. Like, you know, maybe having like coal equals death and then all the bad outcomes. And then,
That
you know, like
gets-
simple infographics.
The
or
thing is that
something.
gets tricky depending on what locality you're in, because if you're
Okay.
in a mining community, people are going to say like you can't use that kind of statement. And so I think I think you have to have something that is not equating somebody's livelihood directly with death. I think that gets very tricky, and it's why like what's his name, the West Virginia Senator Manchin is not on board with us. It's because it's hard to get him when he represents coal people. I think the idea of saying like coal is bad for the miner too, like I think having something about how,
oh yeah,
like I think you have to kind of tie it. I think you can't. I think if you get too simple, I think it gets easy to target against.
Okay.
And I think that's why it got demonized very quickly with us, but that's why I'm getting kind of stuck.
I think kind of sticking broadly to the idea of poor air quality and then like the negative health effects for everyone, somehow being able to show that as a visual and then to connect that to the idea of alternative energy sources and that our hospital systems have the power to impact that. It's like, how do we connect those dots?
I think there's a lot of very clear data on asthma rates in kids based on zip code and what their pollution and air quality is. There's a lot of data on that. I think it gets tricky how to present data like that in something like a protest setting. And so it could be something like a picture of a kid in respiratory distress, like on a ventilator or getting a nebulizer treatment or something like that, like something where they clearly, like, you don't need to be medical to know that a kid looks ill, and then have the visual of the coal plant near their home.
Or maybe you hold up signs with like the color and rating of the air quality of where you live, or the patients, you know, that are coming in, like maybe like the worst air quality in the past month. I mean, everyone, that's like a very visual of like a color and a rating and
in California, that's actually like a universally, like it's a very commonly understood thing right now, after last year.
Yeah.
Right.
I don't know if that's going to work for every locality, but I mean, it's an easy to understand thing. Like red is almost always bad in something like this.
Maybe we run with California just for the idea of for the sake of this kind of exercise.
Yeah. What's weird is I actually don't think you'd have to protest. In like San Francisco, I don't really think I think that's something that might already, like people have already talked about it. Like I remember that when I was like looking at elections last year, people were talking about going like net carbon neutral.
But in fall, I think San Francisco is pretty unique with the fact that they're both progressive and so small, right? So I feel like LA County here,
LA County might be a good one, or like places like in the like Central Valley.
Yeah, absolutely.
Where it's definitely not as overwhelmingly liberal.
Right, exactly.
And it's highly affected by climate change with the fires and air quality.
Exactly. So potentially we have signs with, color and number of air quality of the neighborhoods that are part of the catchment area of the hospital system.
And then another sign with the sick kid, for instance.
Mm-hmm.
So tying it to public health.
Yeah.
Showing that it's a public health issue.
I mean, it's also a race issue as well.
Absolutely.
Yeah, data has shown that like 76% of people are interested in climate solutions if they have benefit of health. That was presented at the American Climate Leadership Summit. It's the number one like co-benefit that people are interested in for climate solutions. So I think taking the health lens is definitely the way to go. Jobs was a relatively close second. And I fully agree that environmental injustice and systemic racism are completely inseparables to this issue. Unfortunately, for that survey, at least only 48% of people are interested in climate solutions if they improve equity. So
I think that might vary though, based on county. If we're talking LA, that might be a lot more, you might get a lot more buy-in from talking about as an equity issue. If you're talking like Central Valley, probably not.
I would agree with that.
I think that's it's definitely something to keep in mind depending on who your community is. And so I think that's where part of this, I think you have to do research on as to who this board of supervisors, like whoever your like county board, whatever we're protesting, like whether it's like the city leadership, like a city meeting or county level or whatever. I think you have to know who they are. And that's where you get into like the things like if you have somebody that's like made their money from mining, maybe not tie it directly to coal, but look more at like air quality idea. Yeah. I think the idea of something like getting a visual of something like if you could do something where you have like, I like the idea of the internal combustion engine idea, like just like a small generator, and then capture the amount of particulates that are produced by that and kind of compare that. Like this is a fraction of what the coal plant is doing, like the whatever power plant you have, and kind of use that as like a visual. You could do something like that. And kind of give it as like a kind of proportion, like this is 1/1000th of it and something like that. I can't really think about that, but I think that's an interesting idea. I think the idea of doing it outside of kind of doing some kind of protest outside the Board of Supervisors meeting, I think is good. And I think focusing on the health aspects, given that data, I think sounds great.
What's our ask? What do we want them to do?
And I think that the most appropriate ask in terms of like to make a difference is to commit to like renewable, like being 100% renewable energy by X date. and like making meaningful progress by, you know, Y date before then, just to make sure you're on track.
Right, kind of have like 3 tiers kind of thing, like, so you get like check marks before.
Absolutely. I think this is an interesting point too, of like, who else can we bring into this aside from, you know, us as being in the healthcare field?
Parent groups potentially.
Environmental groups and environmental justice organizations.
Yeah.
It's like the Sunrise Movement, maybe like Citizens Climate Lobby. There's usually local environmental justice organizations.
Yeah.
Yeah, and I think, you know, definitely communities living next to power plants, factories that are suffering from poor air quality.
Yeah. Potentially businesses where they've had an effect because their employees keep having to call in sick. We kind of talked about the tactics we employ under this with the protest signs, et cetera.
Yep.
I think the skills, like looking at the skills we need and risks.
Mm-hmm.
So some of it is kind of communicating complicated problems in simple language that might play on a 30-second soundbite on the news kind of thing. So something like, it kind of goes to the idea of the cold equals death, but kind of make it a little less judgmental, but more like poor air quality is hurting our children. Something very simple like that. When kids are sick, it means their parents can't work. This means our entire community is impacted by this. And there's something simple we can do, which is use renewable energy that is better for the environment and for our air quality. Kind of make it very simple and very much like focused on like who our stakeholders are and why we're trying to do this, which is helping the community stay healthy. Risks, depending on your institution, they may not like that somebody from their institution, like whether or not you wear like your white coat, for instance, at this kind of a protest. You may get in trouble for something like that. If they have rules about that, you just need to know what those rules are before you do something like this. Like wear a white coat, but not their logo. That kind of thing. And you certainly can get punished for being overly vocal.
Who is going to be the fearless one who shares all of this with the main group?
And cricket.
Do you want to do it, Michelle?
Sure, I can do it.
I just put the link for the Google Doc for if you guys want to take a look at it later, if it's useful at all.
Awesome.
We actually timed that quite well.
Good. It was nice hearing all of your ideas.
Yeah, it's very interesting. Thanks for everybody.
Yeah, thank you. That was awesome.
Lori, I can message you my email, but for the curriculum stuff, Medical Students for a Sustainable Future, which I'm leadership for, has like curriculum toolkit. We also made an elective curriculum here at U of M that I was on the core team for. That should be getting published soon. That I can email you that when that comes out. It's kind of like a framework to look at curriculum specific development within an institution.
That would be fantastic.
That's awesome.
You're at Michigan?
Yep.
Oh,
University of Michigan.
oh,
That's awesome.
I'm from Michigan.
Oh, go blue.
In my
Is everyone back?
Looks like it.
So.
All right. So what we were thinking is it'd be really great to go around, because this is how I get all of my good ideas, and have each group, someone from each group talk about what you guys came up with in terms of the issue you guys were tackling and the people you're trying to influence and what sort of action you guys were going to plan. And then also too, like any difficulties you had or things, you know, mental or other roadblocks that you found in this process that made it difficult for you to arrive at a strategy you thought would be potentially realistic for the real world, so we can talk about it, because the purpose is for you guys to be able to use this in order to plan things later on. And so if there's anything that was difficult or you couldn't get past, we can help work through them if we can. So I don't know if Marie had anything else to add.
Nope, I think we can get started.
All right, let's see. Should we start with education?
Great. So our group did education, and we were talking about how emergency medicine, especially in residency, could be a very homogeneous group. And so the issue we wanted to tackle was how to encourage more diversity. And we talked a lot about what diversity meant. So we talked about not just people of color or people from vulnerable populations, but also people from the LGBTQ committee, people with disabilities and other people who aren't well represented in medicine, who have unique perspectives that can really improve a residency program. And so how to attract that group. And so our goals were focused on the committee, the residency committee. We talked about different strategies about having one person who is diversity focused, always on the group, but then we talked about the drawback of just having one person as opposed to just training the whole group and doing like implicit bias training so that the whole group is prepared to understand the goal of attracting a diverse population and being prepared to see what those applications may look like, as opposed to having the one person. And so we talked about the decision point maker as well, like as that being a point, and also talked about economic points too, where some people may not be able to pursue medicine or have their economic background be part of their decision making. We talked about people in power too, and what these committees look like, how it's hard to change committees. And so Marie challenged us to think about ideas that may be resisted or come across as not being approved by higher powers. So we talked about some of the advocacy ways of doing things. We talked about, like in session 1, about writing articles and op-eds. Then we kind of challenged ourselves to what could be something that would be more I guess engaging. And so we talked about using our own social media to serve as a platform and to speak out with our own opinions, and that doesn't have to necessarily come from this official committee place, or sometimes our own personal narratives are the most powerful way to get our opinions out there, which may be not the traditional opinions. And then we kind of stopped short there because we were realizing that didn't have a lot of bite. And so we were really challenging ourselves, like, what more could we do? Because all those sounded pretty safe and things that have been done before that may or may have not been successful. So we ended there, but we realized that was stopping short of what this is challenging us to do. I guess it's tough to think outside the box when we're so used to thinking inside the box. So I'm glad we're here because we recognize there's more to be done than just that. I think we had a lot of good conversation and getting to know each other. And so I think we probably will end up ending around there.
Okay, great. Thanks for sharing that. And yeah, I think that that is something that like a lot of us struggle is it is hard to think about what that like, what is that next step like, and that doesn't work. So what do we do next? And that often does come with like a little increase in risk and maybe like a little increase in heart rate as you start thinking about it. Does anybody have any like thoughts just before we move to the next group, maybe folks from other groups about like what other tactics people could use that maybe would be a little bit more high risk, but would also be around the issue that this group was working on?
I've been somewhat active in we have a DEI task force at my institution, and we, like many other programs, have instituted a URIM scholarship for students who are potentially going to be emergency medicine residents. And then some institutions are doing scholarships for similar who are doing electives, if they're allowed, during residency, such as EMS, toxicology, PDM, ultrasound, etc. And then also reaching out to younger people in middle school and high school. And there are some programs that are established to engage younger folks, to get them to from a more diverse background, to get them interested in medicine. Those are just some of the things that we've done.
One of the things that I didn't do, but I threatened to do was like a photo sort of series. So when we were trying to get money, so, to have a diversity and inclusion task force, like usually the thing at this stage of the game, I mean, most institutions will allow you to form one, but the question is, do you have the resources to actually create the change that you want, right? Like, is that just in your institution? And what about the whole pipeline issue, which is, I think, the major issue? But one of the things, just speaking directly to your guys' ideas, one of the things that, we kind of envisioned when we were talking about, like, what if, they say no to these monetary requests that I have, what are we going to do, is that we were going to do a series of photo montages where we took photos of the residents and then we basically wrote, does this look like the patient population? And then plaster them all around the hospital, basically on all free walls. And so that's like an idea of something, I mean, it only involved a small amount of risk, which was like, are we going to get in trouble for pasting things on walls of the hospital when we don't have permission, which potentially you could in this vindictive system that we live in. But those are some of the things you can do too, when you're really thinking about, like, how do we get the resources that we need to appropriately tackle this issue at our hospital. And then that's when you can start thinking about art, or you can start thinking about protest, and really trying to pressure your organization to give you more than just like a committee that you're going to basically be volunteering your time on and has no real power or more money behind it.
Thinking of that idea, in a hospital I used to work in, there was a like a very large painting of like a white doctor who was like the one in white coat, right? And this was a hospital in a predominantly Black city, and almost all of our patients were Black. And actually a lot of our doctors were not Black, but a lot of our doctors were international medical graduates. And so we're from like the Middle East. And so you could just make a new painting and replace it as like a better representation of like what the hospital actually looks like, or as a representation of what the hospital could like if they'd chosen to start hiring more Black doctors. Okay, so our next group, let's go to a group that was working on issues around incarceration.
Okay, so if no one else is going to take the lead here, we didn't quite come up with who is going to be a spokesperson, but I can at least start, and anyone else in the group, feel free to jump in. I think we, similarly to the other group, we kind of started thinking of this more from a perspective of advocacy and working within the system, talking about kind of changing policies specifically around patients who are coming into the ED handcuffed, and could the default policy be that all patients are not handcuffed and that officers step out of the room when medical providers go in the room to talk to them. So we were sort of envisioning, well, if we tried doing that through kind of the normal channels and that didn't work, what would be the next step? So one of the ideas that we came up with was, our sort of target was the hospital administration, at least initially, and we talked about, maybe something like doctors in their white coats with handcuffs on, protesting outside of the office of some sort of administrative folks in the hospital. And we kind of broadened that out. One of members of the group, who, if she's here and wants to speak about this, would be great. And kind of mentioned how, even though the hospital admins are maybe initially our target, talk about how we could write as many policies as we want, but the police are the ones with the handcuffs and the keys to the handcuffs. So if they're not on board with that, that's still not going to change. So that's sort of another target as well. Anyone else from my group want to add anything?
Sure. I think one of the points that we were also talking about was making it more of a public action in a public space. That's kind of when we got cut off, but using a day like the mayor's going to get his vaccine, and a bunch of people in white coats show up in cuffs. So media coverage is already there. And then talked about escalating action too. So if that doesn't get us a seat at the table or get anything to get moving, then I don't know, I threw this out there, but like show up in front of like PD, like headquarters, like kind of having this idea of like publicity and escalation also to so it's not just, the people coming out of the C-suite that see it.
I love that. That's really good. And that's a really powerful, I feel like you tapped into like a really powerful image, thinking about like what, like the white coats, like combining with handcuffs, like what does that look like and what does that represent? And also like a solidarity move with incarcerated patients. I think that's really powerful.
I think the other nice thing that you guys did, and I think this is really important, and we didn't really emphasize this, but it's totally true, which is that, it's not always about picking one point of intervention. Sometimes you're going to have to hit at multiple points of intervention to try to get the change, and some are going to be more or less effective than others. And the other thing I like is that you guys were trying to use an event where there's already media, because actually getting media to come to these things and that coordination takes a lot of work. And so to use an event where there's already going to be media present and then co-opt that moment for, a cause that you think is really important is, I think, a really great strategy and really good. And I'm going to put that in my brain. I like the vaccine moment.
I think one other thing that was just important that our group highlighted was that we need to make sure that we are in collaboration with the community, or, the vulnerable population that we're working with, and that the ideas and really that the direct action is like led by their needs and not necessarily what we perceive their needs to be. And then just to echo again, I thought when Louisa, she was the one who said just such a powerful statement that the police are the ones with the keys. So really, I just wanted to re-emphasize that point because I thought it was a really powerful statement.
Yeah, I like that. And I think that that's also a potential, like an imagery that you could work with the idea of keys and how you could do an action around that idea. Because I agree, that's a very catching, it's very true and very telling and catching as well.
And I like that you talked about the layers of power structure that you might need to, like you start in one space, but then you zoomed out and looked at like, well, who else has power and who might have power over the systems that we're used to operating in, and then how do we address that? And yeah, I want to echo, your group brought up really important points about that this does need to be led by the people most affected. And I guess like one thing that highlighted to me about like is that I think the way the worksheet is structured, it sort of doesn't describe that step effectively, that is the first step. And that what we're really talking about is like, once you're working in that collaboration and you've identified that like in your role as a physician, there's something that people want you to do. There's a power structure that the comrades you're working with want you to address, then it's useful to have these tools so that you can understand how to do that thinking and how to plan that action. Because one thing that I think is a challenge for us as physicians is that when we do show up in activist spaces, we often we haven't learned how to do this. And so part of this workshop is for us to learn how to do this. So when that moment comes where we can do a useful action, do some useful planning, we've built those skills already a little bit amongst ourselves, and aren't asking the people around us to teach them to us. Of course, they will always, we'll always be learning new things, but this is to sort of build and strengthen that tool set that we don't always have knowledge of. We had a group that was doing environmental work.
So I'll just delegated to speak for the group. And so one of the things we kind of struggled with a little bit was trying to narrow it down, because I think that's climate change is such a huge problem that trying to figure out one area to focus on was a little difficult. Like we initially started talking about like reducing waste at the hospital, and then we kind of went into alternative energy sources and line 3 and kind of lots of brainstorming. And what we ended up settling on was with an eventual goal for community-based net carbon neutral, looking at using alternative energy sources. And so getting hospitals and communities overall to switch to green sources of energy as kind of like our ultimate goal. And so initially we started that with like the idea of getting our hospital to move to green energy, so wind or solar or similar. And then we kind of broadened that out to what about the entire county, since it may be beneficial, as Lori was talking about, like her hospital is actually, they have a green energy source that's moving to their area. And so the hospital is switching to that and kind of using their power to leverage their employees to do that. And so if we could use the hospital as a way to leverage the entire county or community to move to green, we thought that might be a more effective strategy at getting kind of better switch overall. And so from the hospital, we were thinking about targeting the CMO, and then I went to like the county level. So whatever, like board of supervisors, whether it's a county commission, like whatever that structure might be. Eventually, we thought money is definitely going to be a big part of this. So you kind of have to have some knowledge of what the finances involved would look like. And that also includes things like how many sick days are people losing because of poor air quality, like kids with asthma exacerbations, things like that. And so we kind of need to have that kind of information. The idea that we had as like a point of intervention was a protest outside the county board of supervisors or whatever, like whatever group is in charge of the finances at their next budget meeting to kind of bring this to them. And so our idea was thinking of signs that kind of had pictures about air quality and sick children and kind of targeting the idea of improving health as kind of a way to leverage this. We also had the idea of partnering with community groups like parental groups that can talk about this, and employers that might be losing their, having employees call in sick because somebody's sick in their household and they can't come to work. We also had the idea of using a kind of internal combustion engine or a small generator or something to kind of generate air pollution and kind of be like, this is the problem in a very small scale that we're thinking about, and think about this affecting your entire community as kind of like a way to kind of get a better visual. what we really like eventually want them to do is commit to some amount of renewal, like complete renewable energy by a certain year with like target dates. Like that's kind of what we eventually want. But it gets complicated when you have to think about doing that in a 30-second soundbite. Like how do you make the impact of sick children and kind of air quality and kind of link all that together in a very short sentence. And so that was something that would definitely be a skill that everybody would need. Yeah. Anything else that I missed talking about? Anybody else in our group?
I feel like you all had a really thorough analysis of like a pretty complex and multifaceted problem, which is good. And I like that you were able to like hone down to an individual action. And then you're right, like when you have that broader strategy, communicating like what your ask is in a way that's like, that fits into oftentimes like media spaces or social media spaces, or even just the, friend or a colleague at the, who's sitting next to you, who's like, what were you doing this weekend? Like, I'm sorry, why do you need that shift off? Like, why are we doing the shift trade? And you're like, this is important. Here's why. So that 30-second soundbite becomes important, not just for like the political purposes on the like large scale, but also on the small scale of gaining that buy-in from, friends, family, the people who are going to support you in your work, as to why you're spending your time doing this. So I think that's like a really good skill for everyone to build.
Yeah, I really liked the idea. I like visuals. So I like the idea of, having like a bunch of people coughing on this air that's being generated by your little smoke machine, and what kind of impact that could make in that space. And I think this is a good reminder. We talked about different things people can do, and some of them are like lie in front of a building and get arrested, and some of them are just like, I'm going to have a protest and we're going to have a smoke machine and we're going to bring in the community and we're just going to directly pressure. And both of those can be equally efficacious in the right setting. And sometimes, you do one and then you have to do the other one, or sometimes you can do them in conjunction. The reason why, we used the example earlier in the lecture about the protest that we did right before the pandemic. And one of the reasons that was effective is because we had members of the community and doctors who were just protesting. And then there was a separate group that was also doing the direct action. And those people together kind of created a larger group of solidarity that brought attention to the issue. So yeah, I think I like your guys' idea. I'm signing up to join the protest. Let me know where.
I'll be there too.
What was the last group?
Housing working group.
That's right.
We didn't actually choose a designee for who is going to speak. I'm happy to start with a summary, but then please, if the rest of you want to jump in, feel free. So we, similar to some of the other groups, it sounds like we started by thinking about, oh, this is such a complex issue. Like there's so many levels to it. Where can we focus? And, I think we kind of took maybe the easier way out, where we said, okay, we're going to focus on something that's like more smaller and concrete, that we can kind of wrap around our minds around at the moment. And so that was the issue that many people are not allowed to bring their things into the shelters with them. And often that includes medications. And so then we see them as bounce backs in the emergency department because they didn't have access to their medication and their chronic diseases go all out of control. So we started to think about how could we change this policy so that people would have the ability to keep their possessions with them and their medications, which is important for health, but also like gives people more autonomy as well. And so we thought through, I think we spent a lot of time talking about the barriers because we didn't have time to kind of research who was in charge of, shelter policy and things like that. And also we really wanted to talk with the stakeholders who are the people who actually are, are using the shelters to see, because, there's also, we could potentially do harm as well if, people get things stolen in shelters also. So like maybe some people actually appreciate having their things taken from them so that they don't have to worry about them. So we wanted to make sure that this was actually like a stakeholder focused position before we acted on it. But that being said, the things that we came up with in terms of how to advocate for people being allowed to have their medications, especially, but all of their possessions in the shelters. One thought was to have outside of one of these shelters that has this policy to have like kind of an art installation type thing where we would have like a table covered with people's like, you know, insulin and old, you know, and prescription bottles and things, and like have a protest there, like with this, you know, art installation as the center. And then Dominique came up with a great catchphrase that was going to be check your health at the door, to emphasize the fact that this has like a health impact. And then the second tactic that we thought about was if we were able to get kind of local stakeholders, like we're thinking about the County Board of Supervisors in LA, we were able to get a meeting with them to have at the meeting when the officials were entering the meeting to make them check their possessions at the door of the meeting before they could have the conversation with us, which might be a little bit difficult because they're the ones in power, but it might give them some sense of that little momentary loss of autonomy when they have to check their cell phone that they really want to have with them. So so these were our kind of initial thoughts for like starting with a small piece. Obviously, I think a larger demonstration of like, we want affordable housing for all would be, a much bigger effort, but this was where we thought we would start. And anyone from the group have other things to contribute? I'm sure I missed some other good comments.
No, I feel like you covered it.
Yeah, I think that like, small and concrete is not a bad thing. I mean, those small concrete issues sometimes really impact people's lives. And I don't think there's anything wrong with doing small concrete actions. I think they can be super effective. I liked, making sure you're not doing harm, super important. Usually before any sort of like direct action, after you've spent time with the community, identifying what the issue is, there's a lot of time that's also spent with community groups talking about how the protest is going to go down and what else is going to happen to make sure that it's in line with what everyone feels comfortable with. And sometimes you have to adjust your protest or what's happening. Sometimes people will say, well, we don't want it in this space. We're worried that this might happen as a consequence. They'll shut down the shelter. And then you have to maybe, alter your plans in order to make sure that you're, in line with all the different community groups, which can be challenging. But yeah, no, I think, that's a really good idea. And I like making the Board of Supervisors, have to do something similar to what, unhoused individuals are being asked to do. And it might be that in those discussions that you have with them, they say, yeah, we're worried about our stuff getting stolen, but we would really appreciate lockers, and so you could at the same time advocate for an ideal solution change, which can sometimes be helpful. Marie, did you have any last thoughts?
I apologize, my internet just cut out a couple of times. Yeah, no, so I appreciate the thought around like when you take an intervention, when you do an intervention, what are the downstream effects and what are the potential harms that can be caused? We see this a lot around issues organizing around incarceration and detention, because I think of incarceration often as similar to a hostage crisis, and that like any action you take outside of a detention center, there's a bunch of people inside the detention center who are completely at the mercy of the correctional officers and the guards. And so, we've seen situations where there's pretty intense retaliation towards, people who are being held in detention based on the actions that go on outside. So I think the focus and thought about that is really important. And also goes back to some of the thoughts the incarceration working group was having around making sure that you are like centering and focusing on the people who are most affected by the issue and what they want and what they need. So does anybody have any other things they want to bring up, things that they found challenging during the workshop or anything else that they were thinking about or wanted to comment on after they've heard sort of the other groups' ideas and action plans. I'll also put my contact information in the chat.
Yeah, if anyone ever has questions, if this inspires you to go do some plan a direct action, either with other physicians or with the community, and hopefully with both. If you have any questions, or like there's a lot of logistical things to think through that we didn't go over here because it kind of makes for a boring lecture, you can contact us, or hopefully people can collaborate with one another in the groups. But it was really great to hear everyone's ideas. It always inspires me to hear what things I haven't even thought of, and target points that I haven't considered before. And so thank you for giving this opportunity to us to work with you guys, and see you guys later today.
Yeah, thank you. I really am inspired to hear so many people thinking actively about how to take action both within and outside of our profession. If you found that you really liked some of the ideas you're talking about with someone in your group, or something that was shared, definitely exchange contact information with each other, because this could be a starting place to plan actions going forward.
This was wonderful. Thank you, Hannah and Marie. That was fantastic. We are going to let's take a 7-minute break here. So until 10:05 on the West Coast time here. And then we will transition to Dr. Shamshir Samra, who will be talking about community collaborations. Thanks, guys. All right, we are going to get started here with Shamshir. So Shamshir is going to be talking about community collaborations. I think this will be useful both in terms of when you're thinking about what the issue is that you're advocating for, obviously touching base with the community that you are working with to better understand really what the issue is. And then also as we're moving forward with the action items, getting collaboration from the community as well. So I will pass it over to you, Shamshir.
Cool. Yeah, thanks, Annette. Yeah, thanks everyone for having me. I know people had kind of a long morning, particularly maybe on the West Coast. I also just want to acknowledge it's super cool that there's a kind of a session that was just talking about direct action and protests and advocacy within, SAEM. So really kind of props to the organizers. Let me figure out how to do this. All right. That work? So basically, yeah, to Annette's point, what I wanted to talk about is probably some of the themes that have been discussed this morning already, but basically how relationships with community can be useful and necessary, both towards the ends of helping you bring about change within institutions, I think is the first kind of talk spoke to, but then also how can these relationships put health services and physicians at the service of social movements for broader structural changes. Don't have any disclosures. So why community partnerships? Mostly, how can we think about this and frame it to people we may be trying to sell this to within our departments or organizations? I want to offer a couple of frameworks for what community partnerships can look like depending on the scenario. One is kind of this idea of pragmatic solidarity, and the other one is more of a liberatory solidarity, which I'll get into, and then a little bit of a critical analysis of, what are some counterfeits of community relationships and how it could potentially be problematic. So I want to ground it in a case. You have a patient who's 54 years old, who's recently incarcerated, got out of jail, doesn't have any of his medications, was evicted, status post assault, has some comorbidities. Overall, he's from a medical emergency, traditional emergency department perspective, he's pretty doing okay. He has some nasal bone fractures, but it becomes very apparent that there's a lot of issues that are at play that we're not going to be able to address in the emergency department setting, but then also a lot of issues here that are really going to be impediments to the person's long-term health and well-being. And kind of the old school way of thinking about this was the social determinants of health, which are very much at play. But then also more and more, we've always kind of recognized that the social determinants of health don't affect people in the same way. And that brings up kind of structural violence and the structural vulnerability that individuals have. And this is really, you know, the foundation, kind of the low-hanging fruit of why we need to have relationships with the community, because a lot of these things are outside of our hands as care providers, and particularly, you know, care providers in the emergency department. But I think we have to think a little bit more critically about why we relate with community partners and what those relationships look like. And I think the three maybe kind of grounding ideas are an idea of complicity, you know, our complicity in these inequities that exist and the structure that's present, our responsibility, and finally, you know, humility. And what I mean by that is the complicity part is, you know, societal trends that have happened, right? Since the 80s into the contemporary time period, we have kind of neoliberal transformations in our society where there's been massive increases in inequity, which have correlated with divestment in social spending, support for communities. The real wages of individuals have kind of flatlined and dropped in our society. The thing that's been kind of resistant to that has been, you know, the healthcare sector. And you can see we fall kind of in the middle of the pack of social spending on the, you know, the x-axis here, and on the y-axis, you know, we spend a lot of money on healthcare, which is not a surprise to anyone here. And, you know, we're part of this whole medical industrial complex that is very profitable for many individuals, including ourselves. And when we think about emergency medicine in particular, we pride ourselves as being, you know, individuals that can take care of anyone and take care of anybody who comes through, you know, the emergency department doors. And that's very true, but we also have to recognize that society and politicians and everyone else also recognizes this capacity. And oftentimes emergency care, trauma care can be just enough care, where it's kind of the last vestiges of supportive care systems that exist as we kind of defund primary preventative care and other health promoting services. So on face value, it's like, oh yes, we have this opportunity to serve anyone that comes through the doors, but in reality, the system is set up in this way so that we are the only ones that are, you know, taking care of folks. So it is our responsibility to begin to think about these issues. And then the last part is, you know, the humility piece. And this is, you know, people have probably seen this. This is the original kind of Black Panther's 10-point platform. And you can see health is in there, but it's notably number 6, right? So free health for all Black oppressed people. And I raise this just to say that, you know, oftentimes from the place in which we're situated, health and healthcare outcomes and all these things become kind of at the fore of how we think of the world. And, you know, it's not necessarily a bad thing. That's what we've been charged to do. But relationships with community can better situate what the real priorities and agendas and opportunities for intervention are for community members. And, you know, just going to the example of the Black Panthers Party, a lot of healthcare organizing and advocacy work was done, but it was very clear that the health inequities that existed at that point were framed in a way to be manifestations of broader racism and capitalism that existed in society. So kind of with that foundation, I wanted to kind of go into a couple of these frameworks for partnership. The first one is pragmatic solidarity, and this comes from Paul Farmer and other folks. It's, you know, the rapid deployment of our tools and resources to improve the health and well-being of those who suffer from this violence. And this violence is in reference to structural violence. And if we look at, you know, this picture or this image here, the analogy would essentially be, you know, how do we get as many resources over this wall and over these existing structures to support people on the other side of the wall? And by all means, you know, this is a part of our work, and, you know, we need to do this because there is significant suffering and vulnerability that we need to address in this moment. And if we go back to the case that we started with, you know, this gentleman who's recently left jail and is now, you know, a victim of injury or assault, we know that there's high rates of, you know, re-injury when folks come to trauma centers after an injury. We know that people leaving the jail systems, people leaving, you know, the prison systems have high rates of mortality. So there's obvious vulnerability here that we historically haven't addressed, that we have an opportunity to address. And this has been some of our work in Los Angeles, along with folks on this call, around some of the reentry programs and violence intervention and trauma recovery services. So in this case, where we have an individual with, or a population that has particular vulnerabilities that we're trying to mitigate, it's important to build relationships with appropriate community-based partners who have that expertise. And folks on this call have probably been exposed to or participated in violence intervention work, but we in LA have partnered with a group called Southern California Crossroads, which has a lot of experience dealing with folks who may be involved with gangs, leaving the jail system, and employ and really kind of empower this peer mentoring model to help us address some of these vulnerabilities. Obviously, these relationships are going to look different in different places, but I guess the one critique or thing I want to highlight is that increasingly we're seeing these, platforms like One Degree and Unite Us, which are framed as kind of the Yelps of social services. And I think they can be an incredibly powerful resource to identify who our partners are in the community, but we should never forget, or we should never kind of substitute these digital platforms for the relationships that we build with other individuals in community who are doing health promoting work. And I'll kind of get into why in just a minute. The second part, and I'm going to kind of breeze through this, kind of obvious, is we need to understand kind of the needs that exist within our department, so we can, be able to express to kind of community partners, these are kind of the issues that folks we're working with or dealing with. And in this gentleman's case, it may be that we recognize, we've screened for kind of addiction and, PTSD and some of these other factors. So we can work with our community partners to ensure kind of longitudinal kind of wraparound care. The third kind of principle in this framework is how do we mitigate the barriers? And when we're working with community-based partners, like in some of our programs in LA, the accompaniment piece, which I talked about, is very important. How do we move from basically giving people a piece of paper to say, go to this place to get these services, to having people, meet people where they're at, whether it's in the emergency department, help them get transportation, go get their benefits activated, etc. Creating space within our healthcare institutions for these partnerships to thrive. And this means both kind of theoretically in terms of having individuals join our conversations and meetings, but then also creating physical space for members of the community to participate in the care that we provide in our healthcare institutions. And finally, kind of supporting these wraparound type services. And then the last thing I'll kind of touch upon here, which is, a very important part of this is sustainability. And there's a lot of pitfalls and problems that can arise when there's relationships between the healthcare system and community-based partners. And a lot of it is grounded in the power imbalance that exists, in part due to some of the history that I kind of touched upon already, where the healthcare system has so much kind of prestige assigned to it, so much money assigned to it, so much time potentially assigned to do this work, that it's very easy to kind of roll over community partners. So being very intentional about ensuring co-ownership or even maybe complete ownership of these processes, community-based partners. Humility, and I'll just give kind of one example here where, in our violence intervention work, a lot of the things that we were focused on at the outset was metrics and outcomes and, which social determinants we address, et cetera, whereas our community-based partner had a long history of expertise in the peer navigation and community organizing work, which is not impossible, but it's a little bit more difficult to necessarily quantify on a monthly basis. And our initial kind of tendency was to get our community partner to produce these reports, and they were very interested in making this partnership work. So we noticed that they started to change the way in which they practice, and obviously that can be problematic, especially they have a lot more experience doing this work than we do. So again, just kind of being cognizant of those problems. Recognition of the work that the community is doing. All too often, healthcare providers get a lot of the privilege, prestige, recognition for these programs and kind of become the face of this work. So really making sure to be intentional of uplifting kind of the voices and the true leaders in this work. And the funding piece, just to go back to the previous slides, trying to be intentional as possible to ensure that the funding is going to community-based partners in as much of an unstructured manner as possible, just so that it doesn't necessarily kind of unintentionally kind of force kind of a mission creep in the work that the community-based partner is doing. And with kind of those examples, I guess, in mind, I wanted to highlight some of the problems some additional problems that can arise in these relationships with the community. And people may recognize this kind of old school graphic. It's of like Standard Oil from like the beginning of the 20th century, and it's kind of a critique of monopoly. Obviously, I'm not talking about the oil industry right now, but what I'm talking about is kind of the kind of medical industrial complex and the power we have in our communities and the amount of resources that flow through our institutions. Kind of the name Community and its Counterfeits comes from a book which kind of describes this distorting impact that we have on our communities, and where we have an ability to basically distort what care means, right? It goes from care, which used to historically mean community kind of efficacy within the community, social cohesion, et cetera, to these very case management type frameworks of care. And when we begin with kind of the individual that we're working with, or even kind of the population we're working with in the emergency department, oftentimes we have the tendency to focus on kind of the individual needs and vulnerabilities and lose sight of the structural problems, which the community may be very well aware of. And you know, the second part of that is that we have a tendency to medicalize what it means for care. And this just goes back to what I was talking about, where community organizing, you know, isn't something that is typically something that we fund as a part of our longitudinal case management work. And I think this is kind of an idea or critique that we increasingly have to become cognizant of. In the violence intervention work, there's been a lot of praise and hope, and I think rightfully so, that we'll or we'll start to be able to bill Medicaid for violence intervention services, which is amazing in the sense that we get around, you know, chasing after grant funding and all these other types of things. But suddenly you're going to have millions, if not billions of dollars flowing through healthcare institutions to community-based organizations to do this work. And if the way we're funding the work, the way we structure the work, doesn't recognize the power and importance of community organizing, of direct action, of a lot of the other things that we've spoken about this morning, we have a real ability to even kind of detract from you know, the advocates and activists that are doing the work out there. So the second kind of frame I'll offer as potentially kind of a remedy in terms of relationships is this idea of more of a liberatory solidarity, where you know, we can talk about a liberation medicine as the conscious and conscientious use of health to promote social justice and human dignity. And the key part of that is that instead of health being kind of the end goal there, it's kind of social justice and human dignity. So not things that we oftentimes kind of code for or have an ICD-10 code for. And in the picture, this would be, instead of kind of getting as many resources over that wall or those structures to communities on the other side, it'd be, how do we, yes, get those resources to the other side, but at the same time kind of break down those walls that exist, or even, you know, empower folks to break down those walls to address the structural failures. And it begins with something that folks have probably already talked about, is just an awareness of those structures that exist, you know, kind of moving beyond our individual patient and individual kind of specific siloed need. In the case of this gentleman, it would be recognizing kind of that neoliberal transformation I talked about in LA, but then also divestment and supportive care has been replaced with investments in incarceration and policing. The graphic basically shows kind of the areas that are most heavily policed, or where the money goes in LA County, and also kind of the structural failures where for every dollar kind of spent on the sheriff's department and probation, you see kind of 50 cents in mental health and affordable housing programs. So we can never kind of address the issue unless we recognize these structures that exist. And grounded in that structural competence, approach to how we kind of identify community partners becomes a little bit different. Rather than, you know, being situated in the hospital and reaching out to folks to be like, hey, we have these patients that have this need, how can you work with us? It requires, at least in my opinion, kind of venturing out, using our own time to go out in the community and, you know, see what folks are talking about, see what groups are doing. I know kind of in the last 8 years or so, or 9 years, Since I've been in LA, an initiative began with just going to different community groups and just being quiet. It's sometimes hard for us to do because, we do see so much need and we have so many ideas on how to address it. And just hearing, what folks are talking about, and that at some point kind of transformed into, being asked to, maybe I can share some examples of folks who kind of came out of the jail system and some of the health consequences that they had experienced. But again, the kind of health anecdote and my work as kind of a healthcare worker was situated within this broader kind of abolitionist agenda. Over time that transitioned into participating in, the formation of kind of organized providers who were allied with kind of abolition and decarceration efforts, and finally towards kind of the creation of visions of abolition that included alternative systems of care, which kind of community or healthcare providers participated in. But I think the important part at kind of the outset is that we have to just be there and be present with communities and really understand how we can support those social movements rather than think about how the community can support us towards the end of whatever problem we have in mind, which is a little bit of a flip in kind of our thinking. And this just kind of goes to show that, some of the successes we had in LA County was that, healthcare providers were able to ally with these abolitionist groups to use kind of a healthcare framework ultimately to stop jail construction and push forward dedicated funding to systems of care that were tied to the justice system. And the last thing I'll kind of mention here is this idea of community ownership versus the idea of partnership. And people have probably seen this poem. It's a worker's speech to a doctor, and I just kind of highlighted a part of it here on the right, where it says, your prescription says put on more weight. You might as well tell a fish to go climb a tree. How much time can you give us? We see one carpet in your flat. Can't actually see that part of my screen. Cost of fees you take from 5,000 consultations. You'll no doubt protest your innocence. The damp patch on the wall of our apartments tells the same story. And I kind of put this in there just to highlight some of the stuff that folks have already talked about today. We have to recognize our privilege and kind of the tremendous power that we have, regardless of where we came from. The process of kind of becoming care providers gives us that, whether we kind of deserve it or not. And through that privilege, we often, have a distorted perspective of the issues and problems. So as much as possible, it's how do we empower communities to move towards the end of really gaining control over our healthcare institutions, because as long as the relationships with community remain subservient to the medical industrial complex, it kind of reinforces the existing structures. So this can be as simple as having individuals participate in care spaces from the community, creating a meaningful, not kind of a tokenized community advisory board, to the way we fund projects, but just recognizing that this significant imbalance in power exists, and we have to kind of grapple with it as we work with community and as we move forward. So I know we're kind of at the end of the day, so I'm just gonna wrap it up here and see if folks have thoughts. None of this is meant to be prescriptive. I know folks on this call have probably done, or definitely have done, a lot of amazing work and have their own thoughts, but hopefully it's just a little bit of a, kind of a critical framework to think about how we relate to the community. And, sometimes we have to build that relationship with the community to address that need now, but we just have to recognize the limitations of those partnerships. And so with that, I will close, and that's my email there. Did folks have any thoughts or maybe things they want to share kind of from their own experiences building relationships with community partners?
I had a question, if that's okay. It relates to starting, like, how do you start the community partnership organization when you're thinking about like working with somebody new, and maybe you've identified somebody in your community that is addressing issues that you would like to be involved with. Do you have any recommendations or like best practices, things that have worked or not worked in the past when you're reaching out and trying to, build that partnership and learning how you can amplify what they're doing?
Yeah, I think it's a great question. I think it's going to sound overly vague, but I think it's just being supportive of kind of their work as a starting point, and coming at it not necessarily with kind of prescriptive or kind of plans for what that relationship will look like, but coming to it where you can kind of introduce your role within the health world, the health system, and basically kind of offering up your services and potential platform as a care provider, or the ways in which the health system can potentially amplify their work. Or oftentimes what we've seen is that it's sometimes a lot easier for the health system to draw down funds or resources, whether it's through kind of Medicaid or go after grants that may not be as easily accessible to community partners. So not kind of the best answer, but I think it's just offering up what may be possible and seeing what the community group is interested in. What I found sometimes is going to the community groups that, for example, I went over to one of the day labor centers that's near Harbor where I work. And, I kind of had these thoughts about how we can potentially work with folks who are undocumented in that community. And there was a lot of kind of hesitance initially. And, through the hesitance, it became clear that previously other groups had come in and done these kind of research projects with the community group to better understand kind of day laborers. And the group felt a lot more comfortable with me just kind of, at least initially, just showing up and be present and kind of talking to folks as questions came up. And in some ways, it wasn't kind of the most efficient use potentially my time, but I think, as with any kind of movement or any efforts to really kind of build solidarity, it requires some kind of like sacrifice, right?
I have another question. Thinking about working with communities who maybe want something to happen, but so for example, I'm in a rural community where like in the past I've worked with people who use drugs, and it's really a small, intimate community where sometimes folks aren't comfortable stepping up to do the actions that they want to happen because it's not safe. So I think that applies to like a lot of different populations that we work with. And so in those situations, I've found that it's difficult for people in positions of privilege and more power to not kind of end up being like the face or the leadership, like you're saying, and making sure that the population is still the voice, even though they might have to be behind the scenes like for their own safety. So how do you kind of balance that partnership and also maintaining safety for some of these populations?
Yeah, I think it's a great question. And again, I won't pretend to, I'm sure you kind of know that environment, and I'm kind of based out of like an urban center, so it's obviously a little bit different, but I think you raised kind of an important point. And I guess the analogy I kind of comes to mind is when we were working on a lot of the jail work, some of the community groups had asked, healthcare providers to go to the board of supervisors and give comments and all these types of things. And it's not something that I'm particularly a fan of doing, but that's kind of what the group felt like would be useful, in the sense that we can articulate some of these things. And potentially I felt more comfortable kind of speaking in that venue or setting as some of the other folks who maybe have been recently incarcerated. Not always, but sometimes that's the case. But what followed from that is ultimately kind of the creation of working groups that were created on the terms of people who had been affected by incarceration through kind of our alternative to incarceration process. So I think it's kind of recognizing the violence and inequities that exist in some of these platforms, and potentially working towards creating spaces where people can feel like they can share their stories and their perspectives as well. So, but no easy answer, obviously.
Any
Can
other
you
questions or thoughts? Go ahead, Lori.
Just one quick question. Can you comment on, do you think that it's appropriate or possible sometimes to reach out to people who are not necessarily in your community proper, but who are engaged in work along the lines of what you're interested in, but perhaps, you know, across the country or in a different community, but you still want to leverage their knowledge and their skill and potentially, you know, work with them and join resources?
Yeah, no, I definitely, I think, you know, there's just definitely a value in that. And I guess it's part of some of the luck and privilege sometimes we have, is that we have these networks and we have the ability to kind of affect policy and some of these structures in a way that is easier sometimes. So totally think it's appropriate. I think the thing to be mindful of is trying to keep it grounded at some level in the experiences of people who are affected by whatever issue we're trying to deal with. And, you know, there's so many examples of this, you know, and again, harping on kind of the medicalization thing where, you know, that Black Panther picture I showed where, you know, the sickle cell clinics, sickle cell was used kind of as a manifestation. This is from like Body and Soul. People have probably read this book, but sickle cell was like a manifestation of broader racism and exclusion from the healthcare system. And it was a great organizing tactic to you know, bring about awareness of these issues. And once the medical community kind of started this national movement and were kind of outraged that we weren't appropriately screening for sickle cell, suddenly the focus became on sickle cell and not, you know, these other things. So it's that tough balance of how do we kind of leverage our privilege, but keep it grounded in what the community actually wants.
I have kind of a complicated question. What if different communities want different things? How do you navigate that? Particularly like with the, you know, power and privilege as being a physician or like in a health system role. How do you navigate some of this? Sorry. How do you navigate some of those situations?
Liz, you probably have more, or you do have more expertise than I do. You should answer. But you have a specific scenario?
Okay, I mean, I think that, for example, placement of social services or housing services, for example, in low-income communities and communities of color. Sometimes there's a lot of pushback about that as like, why are you always putting all the services here in like our community, right? Or like, why are the reentry services coming in our community? They should go in like the wealthier part of town or another part of town, for example. But in some sense, you may be putting the service may be going in that community, one, because that's where people are and you want to make them convenient. But there is also a real thing around like where services get placed or what types of, you know, buildings are built in certain communities, which like, they're like, oh, well, we're not going to do that in the wealthier neighborhood or in the white neighborhood, because there's going to be a bunch of NIMBY pushback about that. So, but also at the same time, like, then there's like, how do we build like a more inclusive community where we can do that in multiple different types of communities, where you might, maybe you see the point of view of the low income community that, you know, they want something else built in their community, not necessarily like, I don't know, that's just like a random example.
Yeah,
I haven't
totally.
actually encountered that. Well, actually,
Yeah.
I did encounter that example one time, but it's complex, right? Because, you know, I think that there's multiple layers of contradictions there. I mean, they may not be organizing around that in like a health perspective, but
Right. Yeah, I think it raises a good point, and I don't think there's an easy answer, but I think there's probably like two parts to it that I didn't really talk about. One is like communities, obviously not like a homogenous group. You know, within, you know, sometimes we think about community-based organizations as kind of being community, but we also have to recognize that community-based organizations oftentimes have like 7 different funders, and have very specific things to keep their staff on board. So their vision and perspectives may sometimes run contrary to what other folks may want. And, folks within a particular community, may be similar based on race or class, but maybe not. And there's kind of, distinctions in that. So I don't think there's necessarily an easy answer. I think the one it is a little bit naive to say just, we need to follow community. I think embedded in all this, and kind of the way I framed it, is that we have to have like a political project or vision that we're aligned with. Ultimately, we're picking a vision, and in this presentation is kind of like abolition. So, kind of by virtue of that, it's kind of aligning yourself with communities that would benefit from that vision, or kind of working towards that goal. But I agree, in practice, it can be a lot more challenging.
That's helpful. Thanks.
I think we've probably put you through the ringer enough, Shamshir. Thanks for your help in presenting.
Oh, that's good. That's good. Thanks for having me.
Yeah, absolutely. So Liz and I are going to close out the session here. Thanks for everyone who has stuck around. I know it's been a very long morning, but hopefully a fruitful one.
Thanks, Annette. Maybe we could people could throw their videos on if that's okay. I mean, I think Annette, you had I think a summary slide of some take homes also, but I kind of wanted to. I don't have a big formal thing planned for the closure. I mean, I think there's a lot of really different, really awesome things that we reviewed today. And if people have like reflections or thoughts or things that kind of stick out to them about like something they learned, maybe they didn't know, maybe ways that they were challenged, or things that they maybe have inspired by, that they, even if it's just like, being around a group of people who are committed or excited or energized about advocacy. So these are some takeaways that we did during the session today. So we talked about kind of understanding infrastructure that contribute to the issue you're working on, starting broadly and then we're moving to like more specific types of problems, like discrete problems to solve, not letting perfect be the enemy of the good, and really that can really be a barrier to any kind of progress. And I think that Hemel and Dennis really talked about this iterative process, the kind of doing work and then assessing it and doing it again. And it's that iterative process is getting to a place of more closer to where you want to be, but really trying to movement forward is momentum. Finding your approach within your issue. There's lots of roles for working within the system and outside the system. And different issues or different needs require different types of strategies. They also may develop over time. You may start within system and move to without system, or partner with someone outside system.
And I would just add to that, being okay with however you are comfortable with tackling an issue, because all of these issues, as we've seen today, have points that need to be tackled within the system, whether that is your hospital or whether that is policy, but also need to be tackled from a standpoint of direct action. And so sometimes there's a clear route that is the best for an issue, but ultimately there are a million ways to do this. And I think also just kind of recognizing that part of that is, what is your style? What are you good at? What are you comfortable with? And that is okay for that to kind of direct how you approach your advocacy or activism.
And I would also just highlight that these are strategies, these are tactics, right? So many strategies or tactics can be used to achieve an end goal. And there's a little bit of an assessment, I think, of figuring out what strategy or tactic is going to be most useful to meeting your goal, and how will that end up be working. In addition to balancing what, like your own where you feel like you're most effective at working. But I mean, not to throw it into the awkward Zoom silence, but to throw it into the awkward Zoom silence. If people have, either some lessons learned or things that surprised them, or some takeaways from today, I would love to hear people's own reflections on their experience today.
If anything, I feel very inspired because before watching this, I just felt incredibly overwhelmed and not having even the faintest clue of how to go about beginning. And I felt alone, and I don't feel alone anymore.
So glad, Lori. That's good. Glad to hear that. Other thoughts?
I can share.
Yeah.
So I will be honest, I didn't actually realize I didn't understand the difference between advocacy and activism. So this was really helpful to sort of distinguish between the two of them. And I've also learned, so I'm a med student at UVM, and I'm helping with some of our DEI work in the emergency department, and we are working pretty heavily with community partners. So Dr. Samra's session definitely gave me some thought on sort of different ways to approach the conversations moving forward with our community partners.
Great.
I can go next. I was really inspired today hearing from physicians who have taken risks in activism. I think in the name of professionalism, a lot of times, especially as a medical student, that's not encouraged and is often discouraged. And I feel really excited seeing a community of people who are dedicated to that and willing to take those risks.
I think that's really, just to kind of reflect on like my experience as a pre-medical student. I had done a lot of activism before medical school, and lots of people were like, you need to tone it down because you're not going to get into medical school if you get arrested, like protesting all these things. And I was like, oh gosh, that's terrible. I need to be like careful. And like, but there are a lot of, I think, models of physicians that have, I think of putting their principles on the line in like a different way, or demonstrating them in a different way, and how there is actually space for that. Other thoughts?
I would echo that. I would also say something that I appreciated from all of the presentations, that was the unifying theme, was having a framework to approach each of these issues. Like a lot of times it can be difficult when you have something that you're really passionate about and are just trying to dive in without having a way to think about what are the concrete next steps and what to anticipate moving forward. I really found that helpful to have those frameworks, and you can even like integrate across those frameworks to attack things from multiple angles. So thank you for all the presenters for those.
How did people feel during the direct action exercise? Did they feel like, what kind of maybe personal like challenges? How did it challenge you or push you to grow in some kind of way in terms of thinking about approaching a problem? Was it a new way of thinking? Was it a familiar way of thinking? Scary, freeing? How would people think about that exercise? Rosemary, not to call you out, but you had some, when you were presenting for your group, I thought you had some nice self-reflection on that. I don't know if you maybe people who weren't able to see that, if you would restate some of that.
Well, I was just saying that we all came together and had to establish a framework because we were coming from different points in our career, different locations geographically. And so a little bit of the beginning was more getting to know what perspective each person brought. And then as we worked through a plan, we realized that we had a lot of softballs. And so we were challenged by Marie to think like, what happens when that doesn't work out? Because sometimes we think about these great interventions and then they're either not embraced at these different points of intervention, or the idea doesn't work as we thought it would. And so it's good to think about a second step about what then, and then kind of moving from advocacy to activism and what that looks like when you need to step things up a bit. And that's where our group was challenged, but in a good way, to think about what next.
I think for me, I sometimes, when we were doing the workshop, I would sometimes be thinking like, in some ways I think a bit too critically and thinking, oh, well, we'll probably run into some roadblocks here. But I think sort of on this, like on this slide here, not letting perfect be the enemy of the good. I think that's like I had to sort of stop myself and be like, well, doing something is better than nothing, because even if it's not, well, in some cases, but because even if it's not, even if it doesn't get you to your ultimate goal, you have moved forward, you have maybe like built a stronger connection with maybe like a community organization or like the administrators at your hospital. And I think it's important to just remember that it takes like a few steps, and it's not always going to happen all in one swoop.
That's a great point, Louisa. I think that yeah, we are, as emergency physicians and future emergency physicians, we are like, what is the goal? What is the thing? Did we get to the end? But the process, like those things you mentioned, like the building, they can build on one another, is really useful. I also think, to be a little woo-woo-y for this for a second, I think that our society kind of, I think in general, tries to, our imagination of what's possible and like how to imagine something different and demand and work for that other thing is, we often think, oh, I don't know that I could do that, or we kind of shut ourselves down a little bit. We're like trained almost to shut that down. But having the space to kind of let yourself not only imagine like what else could be possible or how else things could be done, but then fight and advocate for that, and have a voice in that, I think can be like a difficult activation energy sometimes. But what you're talking about in terms of those building blocks, I think can really help, inch that those, whatever, what's the right word I'm looking for? Like perceived barriers or boundaries down a little bit or something. So what are some things that you think you might take from this into your work at your institution? Or how can we maybe apply what we talked about today to work that you have underway or have thought about doing where you live and work and play, I guess.
I think I was encouraged by Dr. Samra's idea of relationships and connecting to the collaborators in the community. And I'm certainly at a space where we need to, our institution may have, as you described, the community being a mixed group and complex. Our institution may have different aligned goals, although we want to care for the patient. We have different different ways of perceiving the problem. And so in order for us to get the health of our patient, we have to collaborate with a community that has a different ability to reach those patients. And so I liked his kind of 4 things that you talked about, and especially the humility, and how do you structure a larger academic institution with these community partners and giving them control and helping them to maintain that in the setting that we are wanting to help, but giving them the control. I think that'll be an interesting balance, but all amidst the relationship. And I think for those community partnerships in the humility part is like,
we're all flawed. We're going to make mistakes. I think people demonstrate their true selves and how they respond to how they like recover from mistakes or how they like try to rectify their mistakes. And that it's okay to be a work in progress. Like that's we're all trying to grow and like and do better. If we were already doing better, we'd be better already, but we're not, we're obviously not there. So I think community work, at least in my experience, has been the humility part is just being like, well, I fucked up. I'm going to try again and to do it better next time. Obviously you don't want to, you want to try to avoid that, but yeah, no, I think that's Dr. Summer's presentation was really excellent. Really excellent. I do want to open it up for some more other general thoughts. And I also just want to say, if you want to be on Zoom like me all day, there is an afternoon session for the consensus conference, which starts in about an hour. Sorry, I have my time zones a little bit confused, right? Annette, right? All right. And and so the people are going to be reviewing works in progress and around different domains. So some of which are about structural inequity, health systems, identity. It's going to be a great session. And Dr. Khaldoon's going to close out our consensus conference series. Today is the third of our consensus conference sessions, and she's absolutely awesome. She is a great example of someone who has done in-system work for health equity and trying to address structural inequities and racism in delivery of healthcare. So I would say if you're interested, it is free to sign up with your SAM registration, so you should come. And if you're interested in general of staying connected to a group of folks who are interested in social emergency medicine, we have our interest group meeting on Thursday, which is at 3:00 Central Time. I think I have the time zone correct. It's also on the schedule, but I can put the link in the chat. You're welcome to come. We have a couple of different work groups that focus on advocacy and research and education. So we would love to have you there as well to collaborate with other folks and see maybe also if you're at an institution, maybe you don't have a lot of other people to either partner with or work with. These are folks nationally that you can build with as well. Any other, Annette, I don't know if you had other thoughts or questions you wanted to bring to the group.
No, I think this has been wonderful. And, as you all know, a workshop is really only as good as everyone is willing to show up and kind of engage. And I think everyone was really interactive today. So I really appreciate you all being here, contributing, standing up for what you believe in. I think it definitely made the morning a lot more powerful. So thank you to all of you for coming. I know all of us feel passionately about all of these issues, and we are more than happy to talk more offline. So our contact information is here. Don't hesitate to reach out. Don't be discouraged if it takes us a couple of days to respond. We're always open to a repeat email. That's not personal. So yeah, looking forward to continuing the dialogue. I'm sure moving forward later this afternoon and on Thursday.
Thank you, everyone. Thank you, Annette, for organizing. Annette did a great job organizing all the whole event today. So thank you so much, and to all of our speakers.
Right. Thank you, everyone. Enjoy the rest of the day.
Have a great day.